afternoon, everyone. Welcome to the University Hospital of the West Indies Emergency Medicine Division webinar celebrating Emergency Medicine Day today, May 27, 2026, under the theme, How It Started and How It Is Going. We apologize for our 12-minute late start due to some technical difficulties, and we will begin this evening's proceedings with a word of prayer from Sister Juliet Harris.
Good afternoon, everyone. So we're going to invoke the presence of God into our midst. And we have a saying in Jamaica that person their children first. So as a part of the Emergency Medicine Division, I want to, invite the presence of God into this proceeding. So let us pray. Almighty God, as we come before you, knowing that you're all God, almighty, all powerful, and we give you glory, we give you praise. We thank you for this afternoon, a day where we can celebrate the emergency medicine team, a day where we can celebrate the work that is done by all the different emergency medicine specialists right here in Jamaica. And we thank you that we are able to come together as a team to be able to celebrate that. And that can only happen because of your grace and your mercy. So as we come before you this evening, we pray that we may take away self and just give you the honor and the glory for everything that will be done this afternoon. We pray that the knowledge that will be given will impact others. It will help others to understand what is done in the emergency medicine, where we're coming from and where we're going. So as persons sit here and listen, we pray, dear God, that your presence may be with each and every one of us. And we pray that the evening may flow smoothly and that everything will go according to plan. Thank you for your presence. Thank you for what you have done and what you will be doing. In Jesus' name I pray and give you glory and praise. Amen.
Amen. Thank you very much, sister, as usual, for that prayer. Of course, we have invoked the Lord into our presence, and we're going to have a especially auspicious occasion as we mark Emergency Medicine Day 2026 and celebrate it at the University Hospital of the West Indies by this webinar. I would like to welcome all of our participants on YouTube. We are presenting from Zoom, so there is a small time delay. So if it is that you recognize that, there's a small delay that is expected, we're hoping that everything goes very smoothly. We have our presenters ready. But before we get started, we would like to hear from our head of the Emergency Medicine Division and consultant emergency medicine physician, Dr. Rhonda Hudson.
Thank you so much, and good afternoon, everyone. So I've been asked to give some opening remarks, so I'm going to open with these remarks. So on this day, emergency departments and programs the world over are celebrating what it means to be a part of a dynamic, ever-changing, and oftentimes stressful society, with its main focus to serve those patients at a most critical and vulnerable period of their lives. Now, according to the emergencymedicineday.org website, this day aims to, and I quote, unite the world population and decision makers to think and talk about emergency medicine and emergency medical care. It means, therefore, that this seminar is going to continue forever. The American Board of Emergency Medicine, the president, Dr. James Thomas, states that the day, and again I quote, is an opportunity to recognize the physicians who stand ready 24/7 to care for patients when they need it most. So this small occasion that we have in our neck of the woods comes alongside the ABEM and the world over in this recognition of our work, but more importantly, to celebrate it. But not just physicians, emergency medicine nurses, lab techs, porters, housekeepers, administrative staff, who dedicate selfless hours to provide excellent care to our patients, despite ever-increasing challenges of personnel and resource constraints. The theme, how it started and how it is going, explores not only the history of emergency medicine in Jamaica and to some extent the Caribbean, but I dare say the diversification of the emergency medicine graduates to encompass so much of what emergency medicine embodies. Today, you will hear graduates new, or you will hear from graduates new and not so new. And by the end, it is my hope that all of us in emergency medicine will already have formulated which frontiers we will conquer next. From the Accident and Emergency Unit at the University Hospital of the West Indies, I thank you for your participation in this celebration and trust that you will have been edified. Good afternoon and thank you.
Good afternoon, and thank you very much, Dr. Hudson, for those warm opening remarks. Emergency Medicine Day is extremely special to us, and hence last year we had a whole week of activities. This year we are no less, we are doing our webinar, and as you said, our learned speakers are online and ready to educate and inform us about emergency medicine as a specialty, as well as to give us cases that we can take away to our neck of the woods, right? Wherever you are in the world regarding emergency medicine and how we should continue to manage patients based on the standard of care that we are expected to. So, coming up, we have our keynote speaker, Associate Professor Dr. William Burke. And today he has offered to give us this talk on the origins of emergency medicine as a specialty. Now, Associate Professor Dr. William A. Burke has an extensive resume, and I am going to attempt, sir, to summarize. I'm hoping that I will do you justice, as you know, you have, as I said, quite an extensive resume. He is an associate professor in the Department of Emergency Medicine, Wayne State University, Detroit, Michigan. He has also served there as an assistant professor. He's an instructor in internal medicine. He has served as medical chief of information officer, chief of staff, and vice chief of staff. He has also served as a casualty officer at the Kingston Public Hospital, and that made me excited. He is attached to many major professional societies, such as the Annals of Emergency Medicine. He is board certified, not only in emergency medicine, but in internal medicine. He has served on many societies. He has received lots of honors and awards. He has taught at the Wayne State University from 1987 to present. He is highly published with several papers, case reports, and article reviews. He has extensive knowledge of emergency medicine as well as internal medicine. With such a decorated CV, help me welcome our keynote speaker, Associate Professor Dr. William A. Burke, to speak to us on the origins of emergency medicine as a specialty. Over to you, Dr. Burke.
Dr. Edwards, thank you very much for that very generous introduction. And thank you for inviting me. I'm very interested in hearing what all the other speakers have to say. I'm going to share my screen and show some slides. I'm going to start with, I think, is the motto for emergency physicians anywhere, which is anyone, anything, anytime. Certainly a motto which would not fit any other medical specialty. As Dr. Edwards said, I have some experience working in Jamaica, and I'm going to splice my personal history in emergency medicine into this talk because, like many people in the beginning of the specialty, I was pulled into the specialty, which needed people who were ambitious and energetic. And I got drawn into the specialty, although I was not planning to become an emergency physician when I was in medical school and doing my specialty training in emergency medicine. This is my ID tag from my time as chief casualty officer at Kingston Public Hospital. The earliest days of U.S. emergency care started back in the Civil War, and during the Civil War, military surgeons developed organized battlefield triage and ambulance transport systems. In 1862, Jonathan Letterman created the Union Army Ambulance Corps, which are often considered the foundation of modern EMS. In 1865, the city of Cincinnati launched one of the first civilian ambulance services in the U.S., and in the late 1800s, urban communities began creating what they called receiving rooms for emergencies. Letterman's stage battlefield triage is the basis for triage as it has come to be today. He created a field dressing station that was located on or next to the battlefield, a field hospital located close to the battlefield for emergency surgery, a large hospital located away from the battlefield and providing facilities for long-term definitive care of patients. And his methodology proved amazingly successful. At the Battle of Antietam in September of 1862, there were over 23,000 casualties, and medical personnel were able to remove all of the wounded from the field in just 24 hours. Before that, it could take days, and as you can imagine, many people died while being waited to be evacuated. In the 1940s, physicians returning from World War II brought advances in trauma resuscitation, shock management, blood transfusion, and battlefield triage. And of course, these wartime experiences, as is always the case with wartime experiences, heavily influenced the later evolution of emergency medicine. From 1950 to 1960, we had the pre-specialty era. Emergency departments became busier as hospitals expanded and suburbanization increased. However, emergency care on arrival to the hospital is provided by the most inexperienced and poorly trained physicians. Ambulance services were often run by funeral homes or police departments, and sick patients were often brought to the hospital by family or friends. And at the same time, advanced technologies for resuscitation began to emerge, such as defibrillation and CPR. And here's a picture of Detroit Receiving Hospital, which is the hospital I've worked at in Detroit for many years. This is from the early 1960s. And as you can see in the center of the photo, there's a hearse, which has just brought somebody to the hospital. And if you want a definition of conflict of interest, there's a funeral. The example would be a funeral home bringing a sick patient to the hospital. 1952, a watershed event in my career, I was born. Robert H. Kennedy gave an oration on trauma at the American College of Surgeons meeting in 1954, and he said, "There is little doubt in my mind that the weakest link in the chain of hospital care in most hospitals in this country is the emergency room's attention to the injured." And just a quick note, Robert H. Kennedy is no relation to Robert F. Kennedy or to anyone else in the famous Kennedy family. And here's a table from his oration, Our Fashionable Killer. And as you can see, he pointed out that among children aged 1 to 14, accidents were the predominant cause of death. So a big opportunity for improvement there. In 1964-65, there was a big event, and the funding became available for emergency and general medical care. Congress passed Medicare and Medicaid legislation, which created a funding source for patients in need of emergency care. Medicare is administered nationally, and it funds medical care for those who have worked in the U.S. and are 65 years of age or greater. Medicaid, which is administered by the states, but to a large extent funded by the federal government, provides care for the economically disadvantaged. And as you can see, put together, these two programs cover 137 million people in the United States, nearly 2 in 5 or 40% of the entire population. 1960s saw the birth of emergency medicine as a specialty. Public demand grew for better emergency care. Physicians began working full-time in emergency departments instead of moonlighting while concentrating on their core specialty with most of their time. 1966 saw another watershed event, which was the publication of Accidental Death and Disability, the Neglected Disease of Modern Society. It's often referred to as the white paper and exposed poor trauma and ambulance care nationwide. The report directly led to EMS reform and to standardized EMT training. In 1968, the Professional Organization of Emergency Physicians, the major professional organization to this day, the American College of Emergency Physicians, was founded. It was founded by 8 physicians participating in Lansing, Michigan. Almost all of them were practicing in what is now my home state, Michigan. It is a national medical society representing emergency physicians, residents, and medical students. It educated second career physicians and furthered the development of the discipline, and their first ASEP scientific assembly was convened in Denver in 1969. The early 1970s saw the birth of emergency medicine as a specialty. In 1970, the first emergency medicine residency program was founded at the University of Cincinnati, and in 1971, the first academic department of emergency medicine was founded at the University of Southern California. And between 1975 and 1980, more residency programs developed nationwide. 1970s saw further EMS development. The EMS Systems Act funded regional EMS systems and paramedic programs, and EMT and paramedic training standards became more formalized. 1970s saw specialty recognition. In 1973, emergency medicine gained provisional representation in the American Medical Association, and in 1975, the AMA approved a formal emergency medicine section. In 1976, the American Board of Emergency Medicine was incorporated, and in 1979, emergency medicine became the 23rd formally recognized specialty in the United States. In 1975 to 1979 saw me enter and then graduate from the medical school at the University of Michigan. I matched with an internal medicine residency and really don't know anything about emergency medicine, and neither did my classmates. We all hear that one of our 205 classmates matched with an emergency medicine residency, and I and the rest of my classmates wonder, what is all that about? 1980s saw the expansion and professionalization of the specialty. EM residency programs expanded rapidly. Board certification became standardized. Trauma systems developed nationwide. ACLS, ATLS, and pediatric advanced life support courses became widespread. Emergency departments became central hospital entry points. 1986 saw the Emergency Treatment and Active Labor Act, which is often referred to as EMTALA, passed by Congress. And public hospitals in Chicago, New York, and Dallas had documented cases where critically injured patients and patients in labor were shipped to public hospitals without proper stabilization. In the United States, this is often referred to as dumping. State and federal investigations at the same time had found hospitals were screening patients based on insurance status before treatment and refusing care to people who had none. EMTALA fundamentally reshaped U.S. emergency care access, requiring emergency departments to evaluate and stabilize all patients regardless of their ability to pay. 1986, again, the EMTALA Act, and it requires a medical screening exam be performed for all patients presenting to emergency departments and that they be stabilized before transfer to a higher level of care. And that supported a core value of our specialty, which is to provide care guided by medical necessity rather than financial means. That is to say, anyone, anything, anytime. In my own life, in 1982, I graduated from my internal medicine residency. My plan was to specialize in cardiology, but first I wanted to practice abroad. From 1982 to 1985, while I was applying for a position at KPH, I worked in a public hospital ED in Michigan. And doing that was a very common thing for physicians who had recently graduated from non-EM residencies, who for one reason or another wanted a career break before moving on. In 1985, the Jamaican Ministry of Health said to me they didn't want me to work on a KPH internal medicine firm. That was the job for which I'd applied. Because of my massive 2-year experience in emergency medicine in the United States, they offered me a position as Chief Casualty Officer at KPH, a position I accepted and fulfilled from 1985 through 1987. 1988 to 1992, the American Board of Emergency Medicine had a practice experience-based pathway for board certification so that all the physicians who had been practicing emergency medicine before residencies came into being had a pathway to board certification. In 1987, ABEM granted me a waiver. They allowed me to count the 2 years I practiced in Jamaica toward the 7-year practice requirement, which nominally had required practice in the United States. In 1988, I passed the oral and written exams and became board certified in emergency medicine. This is a pathway that many physicians who were older physicians like myself took to become board certified in emergency medicine. In the 1990s, the specialty realized academic maturity and there was systems development. In 1990, ABEM achieved full primary board status, and as creative and unique research work by EM docs emerged, emergency medicine became recognized as a viable academic specialty. Managed care came into being and increased ED crowding pressures, and in 1996, the EMS Agenda for the Future promoted integrated EMS systems. 1991 was a big event in my department. We ceased being a section of the Department of Surgery and became an independent Department of Emergency Medicine at the university, which was something that happened across the whole country with sections and departments of emergency medicine. 1990 saw emergence of EM subspecialties with fellowships in pediatric emergency medicine, toxicology, ultrasound, and EMS. In the 2000s, emergency departments became a healthcare safety net. ED volumes rose dramatically. Emergency departments increasingly functioned as a healthcare safety net for the uninsured and underinsured patients. And in my own practice, I found patients frequently came to the emergency department because they knew they would be seen quickly and they didn't have to wait in a doctor's office or wait for a long time to get an appointment to see their primary care physician. Point of care ultrasound expanded rapidly, and EM became a highly competitive specialty among medical students, thanks in large part to the hit medical drama ER. And I'm told that the same thing is happening with the medical drama The Pit today. The 2000s continued. There was the emergence of highly specialized care of complex emergencies, which necessitated the participation of EM as the doorway into the hospital. And these included stroke centers, treatment of myocardial infarction, and sepsis protocols. Disaster management also came to the forefront, especially after the September 11, 2001 attacks and after Hurricane Katrina in 2005, which devastated New Orleans and much of the U.S. southeast coastline. In the 2010s, emergency medicine became one of the largest hospital-based specialty, and we saw the widespread use of bedside ultrasound, continued evolution of electronic medical records, telemedicine being incorporated into emergency medicine, the advent of advanced resuscitation protocols, and the opioid epidemic, which heavily impacted ED practice. There also was a greater focus on social determinants of health and public health roles in the ED. In the 2010s, concerns arose. It became clear that physicians who practiced in the emergency department for many years were subject to burnout. ED overcrowding became more and more of an issue. There were boarding crises with a large proportion of emergency department beds being taken up by patients who were waiting for beds in the hospital, compromising their care as well as the care of patients newly arriving in the emergency department. Another issue which arose and has continued to be an issue is the corporatization of ED staffing. 40% of US EDs are now run by for-profit contract management groups, a number of which are listed on major stock exchanges, and profit before excellence in medical care increasingly became a theme in American healthcare. In the 2020s, we had the pandemic era and workforce debate. COVID-19 pandemic placed emergency departments at the center of the national crisis. EM physicians managed surges, ventilator shortages. At my hospital, we nearly ran out of ventilators for patients who needed them. Disaster triage, staffing shortages, and telehealth and virtual triage accelerated. At my own hospital, we implemented telehealth to do triage during the COVID pandemic. In the 2020s, national discussions emerged about emergency physician oversupply with shortages in rural areas, continued problems with corporate staffing models affecting quality, workplace violence against all types of caregivers, an increased integration of AI and concerns about what effects it would have on the role of physicians as caregivers. And I can tell you, speaking to my own residents, they are very concerned about what AI is going to do to their own employment and to the working conditions they'll experience as they go forward in their careers. From 1987 to 2023, I practiced EM at Detroit Receiving Hospital, and I was on the faculty of Wayne State University. I retired from clinical practice, but continued to teach and learn, my concentration on ECGs, providing opportunities for both teaching and scholarship. Just to finish, just for fun, these are two articles that I published based on my experience in Jamaica. One of them just about the experience in Jamaica, and the other one, an evaluation of the golden period for wound repair. I had excellent help from two junior doctors working at Kingston Hospital, Devin Osborne and Devin Taylor, and that article dispelled the notion of a golden period for wound repair and established that almost all lacerations can be closed at any time from wounding to presentation, as long as they're not grossly infected. So thank you very much for listening. I've really enjoyed giving the talk, and I am really looking forward to hearing what the other speakers have to say. Thank you.
Thank you very much, Dr. Burke, for bringing us down to memory lane and reminding us of the publications, the local publications that you actually had at the Kingston Public Hospital. I am very happy that you got a chance to give us an idea of what things were back then and to bring us forward to the major developments in the specialty of emergency medicine. Even though I realize that you're bridging the gap with internal medicine as well as emergency medicine. Okay, we're moving on to our next speaker. Our next speaker is regional, but no less decorated. Dr. Reggie King is an important figure in the development of emergency medicine in the Caribbean. He embodies the evolution of the specialty from its formative year to its modern academic grounded practice. He's a graduate of the University of the West Indies, and he also did a Master of Science in Emergency Medicine, as well as his DM in 2002. His career parallels the maturation of emergency medicine as a recognized specialty in the region, particularly in Barbados and the wider UWI system. He has served as senior lecturer in emergency medicine at Caveville campus. His commitment to academic excellence is reflected in his mentorship of residents. He has helped to standardize training and foster cross-campus integration, strengthening regional identity of the discipline. He is deeply involved in shaping emergency care delivery at the Queen Elizabeth Hospital in Barbados. His leadership spans service development, departmental expansion, disaster preparedness, and pandemic response, including contributions during COVID-19. Beyond the hospital, his influence extends to research, regional collaboration, and public engagement. His publications address key issues including physician burnout, pediatric emergencies, and the impact of interpersonal violence, reflecting the unique challenges of Caribbean healthcare. Through teaching, advocacy, and innovation, he represents a generation of clinicians who have transformed emergency medicine from service into dynamic academic and clinical specialty, shaping its history and future across the Caribbean. Help me welcome Dr. Reginald King as he speaks about emergency medicine in Jamaica and the Caribbean. Over to you, Dr. King.
Can you see my screen? Yes.
Yes, sir.
Okay. All right. So there was a slight edit because of the the topic and the difficulty of using Jamaica as the main example from here. So it is on the development of emergency medicine in the Caribbean, giving examples from the campus territories and focusing. Most of my examples come from Barbados, but I've tried to, as much as possible, get them to the other countries as well, because I think we all face the same difficulties. Just in case people don't know, the flag on the right-hand side of the screen is the flag of the West Indies Federation, which led then to the formation of UHWI. The striving for regional integration. Okay. This picture, which you see before us, is one of the major features in emergency medicine in the Caribbean. Dr. Harold Watson, and this was as his introductory registration at Mona and his picture, complete with afro. So the idea of this lecture is to discuss the historical context of the development of modern emergency medicine in the Caribbean, to identify important landmarks in the growth of the specialty, and to explain challenges faced by Caribbean emergency departments. Emergency medicine does not exist in a vacuum. Disease prevalence and treatments available impact the care offered by an ED. And we need to understand the changes in specialty. Therefore, we have to understand the circumstances of the time. Right? I'm going to start way back. Slaves were viewed as valuable property, and they actually had slave hospitals, particularly in the Cane countries, Barbados, Jamaica, Trinidad. Bahamas was slightly different, as they were not a sugar colony, and it actually was better for their slaves in that they could access the hospitals that the masters used. In the rest of the Caribbean, that was a no-no, and they only really got what care the traditional healers could offer. So when slavery ended in the British Caribbean in 1834, people moved from the plantations into urban settlements. The slave plantations closed as the owners no longer had any responsibility for the slaves, and it resulted in really social and healthcare conditions that were terrible. The exception was in Nassau. As I said, their hospital at the time was able to treat Black patients. In Trinidad, Jamaica, and Barbados, that was not true. KPH was opened in 1776, didn't accept Black patients until 1838. Right. This was the older picture of the what became PMH in Bahamas, Princess Margaret Hospital. Because of the social conditions, they had a whole set of diseases which we no longer see. I suppose measles is now making a comeback because we have chosen as a population and as a people to no longer immunize. But diseases like leprosy and yaws, and yellow fever and malaria are now unusual and really occur where people come from outside the region of the English-speaking Caribbean. Okay. Protein allergy malnutrition was still around as a medical student. I haven't seen it for quite a while here, and I don't think it is seen regularly elsewhere. So this was our old hospital. Those persons who have come to Barbados to examine, that is the compound that we have our examination center on. We are at the easterly end of the compound, and these old buildings are on the west. It was a 450-bed hospital, and this was the medical staff and the head of nursing for that hospital. This is KPH after the 1909 earthquake. Again, a fairly primitive setup in all these hospitals at the time, offering basic care because this was before the era of antibiotics and even IV fluids. In Barbados, things like boarding and patient abandonment were a problem even in the early hospital. They had a case where a patient was taken from the hospital after he had spent more than 6 months there, and the hospital directed that he be moved in a cart after his relatives would not come back for him. Staffing was so bad that the surgeon, who was resident surgeon, not being a resident, but a surgeon who was attached to the hospital, he wrote an official complaint to the matron for refusal to staff the casualty in the 1900s. At that time, the hospital was seeing 400 patients a day, but after hours, there was only a single on-call doctor who provided care in the casualty and on the wards. Anecdote from a family friend: her brother was shot himself while he was cleaning his gun. He was taken to a hospital. The on-call surgeon was at home and decided he wouldn't come out until morning. So he was placed on a ward and kept until daylight, when he was given an enema in preparation for surgery. The bullet passed in the bowel movement and the patient was discharged without surgery. So care at that time was not the best. Although you have to say that her brother only died last year, I think, or year before. So he survived despite our best efforts. This is a depiction of the Trinidad sugar riots, which occurred in the 1930s, with a set of Caribbean riots that went from Trinidad in the south all the way up to Bahamas, and resulted in the UK sending down a commission, which became known as the Moyne Commission, to investigate the circumstances which led to the riots. And this is Lord Moyne. This was the crowd outside to give evidence or listen to the evidence presented here in Barbados. And similar crowds were seen throughout the Caribbean. So Moyne discovered that really the care offered in the Caribbean was horrible. You can see what our death rates and infant mortality rates were in the 1920s and 30s. Now, after the Moyne Commission, it gradually improved because of the introduction of public health and outpatient clinics. In 1928, Barbados was having 30 deaths per 1,000 for adults and an infant mortality rate of 331, which is incredible. Out of the Moyne Commission came the drives to start UHWI, and which was then University College of the West Indies. This was the first group of students on entry. They accepted 33 out of 800, which means that this was the best that the Caribbean had to offer. UHWI was built in 1953 and was the first teaching hospital, followed by St. Augustine, QEH, and most recently, Princess Margaret in Bahamas. These were the first graduates at around that same time. And if you look at life expectancy over that time, we can see that over the 50 years from 1950 to the 2000s, life expectancy throughout the Caribbean has increased by 20 years. And as doctors from UHWI, I think we have a large part to play in that. QH was built starting in 1962 and finished in 1964, having 600 beds, only 43 doctors, and overcrowding was a big deal. In fact, 2 patients on a bed was nothing unusual. One of the recommendations soon after was that casualty should have a spot for a doctor to stay in all night on duty, which was a big event. The doctor was then there anytime something came. In 1973, a committee set these goals of eliminating overcrowding, creating a better public image, and all similar things that we continue to have as problems. The casualty was seeing 250 patients a day by now, decreasing from 400 the first time we visited daily visits. There was a USAID program which brought emergency physicians to Barbados, Dr. Van Tyne and Dr. Ellis. And one of their views was that emergency medicine needed to be a specialty in Barbados to result in significant change in the emergency medical system and in care in the hospital. They complained that patients were being seen first come, first served. There was no triage. It was chaotic and unsafe. The staff was poorly trained. And therefore, they started to introduce triage. They increased the number of examination rooms, and they had inventory management. They introduced physician scheduling. And then because of a decrease in the number of patients caused by extended hours in the polyclinics, things began to improve. Again, the complaint was that there was no formal EM training, and that began solely to take root in the eyes of the political directorate. So improved quality and efficiency are less visible to the general public, whose criteria are often how quickly I'm seen or how pleasantly I'm treated. And I think that's true everywhere in the Caribbean that emergency medicine is, and everywhere in the world. Patients want to be seen fast. They don't know how good you are at seeing them, but if you're nice to them, that's what they want to get. So in 1990, Barbados built its first emergency department as opposed to casualty. This is Dr. Rana Naidu, who was the head of the department at the time, and along with him, Dr. Irvin Branker. Right? This was the opening of the A&E, which was purpose-built. It had 2 resuscitation rooms, 13 treatment rooms, a procedure room, an asthma bay. It had x-rays in the department and a central elevated workstation. These are members of staff and our actual ambulance bay, which had at the beginning a roller door to close the ambulance entrance to the view of the public. Staffing improved. We had 2 consultants, neither of whom was an emergency physician. The 3 residents, Dr. Watson, and Dr. Wharton, and Dr. Bishop. And as the internship included at the time, 6 months after the major specialties, we had interns and SHOs as a major part of our staff. As part of the opening of the new department, there was an attempt to create great staff camaraderie, increased morale, and they took the staff to a local hotel for team building exercises. And Dr. Watson is again in the picture in the blue velour tracksuit. Things improved over time, and they had good team relationships. Again, this is Dr. Bishop and Dr. Wharton. A&E was putting on casts on their own. They had, PAHO had a trade winds exercise. And the department began to grow. So the start of emergency medicine involves these three individuals: Professor Lenworth Jacobs from Hartford, Professor Earl Walrand from Barbados, and Dr. Rana Naidu, who at the time was the head of the department, and a family physician who had recently done research into late night calls at the polyclinic, which showed a need for emergency services. Right? At first, it was a 3-year program as the MSc, and then an optional 4th year to do the DM. Then that changed because there was a few of the residents were taking on the work of going on to the DM. So DM became a 4-year mandatory program. And then it was split into DM Part 1 and DM Part 2. DM 1 looking at basic sciences, and DM 2 being clinical and academic in nature. Okay. UWI Barbados has graduated 48 DM graduates in that time. And currently now we have 13 residents in the program. We have gone from 1 lecturer to 2, and our associate lecturers have gone from 1 to 5. Around 1997, we attempted to offer a short course in emergency medicine for the territories in Eastern Caribbean that did not have a emergency medicine program. And candidates came here for 6 weeks and did short rotations through various specialties. The head department in QEH changed from family physicians and a surgeon, eventually to having all emergency medicine trained persons who had done the DM. And that was a major change in thought processes, as emergency medicine was leading emergency medicine. Professor McDonald, seen on your left, visited Barbados, was impressed by the program's success, and took it home to Jamaica. On your right is Dr. Bullard, who eventually take it from Jamaica to the Bahamas. All right. So as DM-EM spread, we eventually had all Caribbean-trained emergency physicians leading emergency medicine and the campus territories. This was the first class in Nassau. Dr. Davis, Dr. Wells, Dr. Davis McKenzie, and Dr. Nairn, who unfortunately has passed. In terms of production, we have produced 48 residents in Barbados, 76 in Jamaica, 46 in Trinidad, and 16 in the Bahamas. Dr. Sami then started the diploma program, which was a modular EM course aimed mainly at persons who wanted clinical qualifications. And that has been a huge success, producing 236 graduates. And then went to Jamaica, where they had a further 21. As usual, emergency medicine is a team specialty, having doctors, nurses, orderlies, housekeepers, operators, technicians, all involved in the care of the patient. In 2016, another review of the emergency department found similar problems to the 1930s, poor morale, inadequate numbers, lots of patients who could be seen elsewhere, inadequate triage, inadequate referral processes. And that resulted in an improvement in the triage system using CTAS, which was a 5-tier Canadian triage acuity score. And most of our patients were found to be non-urgent, but needing investigations or care that could only be offered in a hospital. Those are the category 3s. Category 1 and 2 were reasonably low, less than about 12%. And then 4 and 5, who could be moved elsewhere, were in the region of 25% and less than 10%. In the late 2000s, we faced several challenges throughout the Caribbean. COVID overwhelmed us with numbers of patients requiring airway management and oxygen. And this was COVID and a makeshift method of transferring patients in Trinidad. The deaths were frightening, and these graphs were daily outputs of the public health system, and everyone in the Caribbean was glued to see how many deaths were occurring everywhere else. Is it getting worse? Is it getting worse again? And then all of a sudden, vaccination occurred and COVID disappeared as a risk. Hurricanes affected Jamaica, Bahamas, Jamaica again, as climate change became a part of the 2020 emergency medicine milieu. Barbados experienced volcanic ash fall from St. Vincent, which put almost a foot of ash over everything. And it, as you can no doubt imagine, led to an increase in respiratory illnesses. Mass casualties have increased as persons become more reckless and the roads become busier. Violence in the society has increased, leading to more patients coming to the emergency department. Shootings are a regular thing. And this was from the Small Arms Survey, looking at violence in the Caribbean, in Jamaica, Barbados, and Bahamas. And this was a big cost to the Caribbean. Patients stayed in hospital for 10 to 15 days. They required multiple consultations and investigations, needed surgeries, and all these things all passed through the emergency department. As violence became higher, the emergency department faced violence actually on the compounds. And that is one of the major fears of our staff, that a gunman will come into the hospital and begin to shoot staff members. As the Caribbean becomes more well off, we've had an increase in non-communicable diseases. And these represent a major problem with a number of days of active living, how much we've lost from our populations, which are already small. This is a big burden. And all these people come to the A&E with strokes, heart attacks, cancers. And it doesn't seem to be slowing down as obesity increases in our children. Mm-hmm. 75% of deaths in the Caribbean are due to non-communicable diseases, and almost 10% of our GDP is spent on treating them. The EDs are overcrowded. This is at Mona. This was in Barbados. The news and social media have almost nothing good to say. And they only publish bad news about the emergency department. This was a famous social media post which claimed that this was happening in our hospital in Barbados. This, however, was not in Barbados. It was actually another Caribbean island. But social media doesn't have to be true, and fakes spread far. And all these things lead to burnout among our staff. This was a paper by Dr. Lovell looking at burnout in Barbados, Trinidad, and Bahamas. One of the things that came out of all these problems was a desire to rebuild the emergency stock. So we've had an increase in Barbados in our emergency department to approximately twice the floor space. It looks now much better and has improved patient areas. We've also seen, because of the program, the development of private emergency care being offered at urgent care centers staffed by emergency specialists. One of the problems with that, though, is that then there is a desire for staff to leave the hospital and a pull towards private care. The staff of the QH has increased, with now almost 20 of our staff having DMs, and another 13 being in training. In the rest of the Caribbean, the same similar numbers. All the public hospitals in Trinidad have DM leadership in the emergency department. And Jamaica, all the type A and type B hospitals. In Bahamas, both of the major hospitals in Nassau and Freeport. Recently, Antigua has joined it and now has 5 DM trained physicians, 3 who were trained at Mona and 2 who were trained in Barbados. St. Vincent and St. Lucia have emergency physicians from outside the region. Emergency training has led to improved training at all levels. And there is now regular teaching, both here and in other territories, both residents, students, orderlies, and nurses. There are the resuscitation courses being offered, largely driven by emergency medicine, mass casualty training, triage, and ultrasound training. Post-residency, lots of our doctors have undertaken training, including in toxicology, EMS, geriatrics, ultrasound, sports medicine, critical care, occupational health, allergy, disasters, EMS, simulation and pediatric, emergency medicine, and forensics. And then even more have gone on to do postgraduate training in the terms of the MBAs or MHAs, and have gone on into public health or into leadership in emergency department. So this is just a basic idea of why the hospitals have had the problems that they have. They are the source of care or the endpoint of care for many, many persons outside the hospital. And the flow for these systems all depend on the hospital being available to take their more difficult patients. In Barbados at one point, we were 20% asthmatics, 25% trauma, and 55% non-trauma. The asthmatic numbers have fallen, and the non-trauma cases have increased as our myocardial infarctions and strokes increase. Most of our patients are category 3 in our 5-tier system. And patient flow in our department applies to all emergency departments in the region. The patient first goes to the triage system where they meet a nurse or a doctor. Then, depending on how crowding is, they're offered a bed. Then they see the physician, and that interaction may take 10 to 15 minutes in general before they enter another queue for investigations. The serial queuing continues as they wait for specialists or persons to decide to refer them. And lastly, the wards in all of our hospitals are now full. And every day, therefore, we have 20 patients in Barbados, 50 patients in Trinidad, waiting on admission. And this leads to overcrowding. The numbers being seen in the hospital have fallen from 400 in the 1900s to 75 now. And that has happened because patients have more places to seek care. But despite that, we're still getting the same number of 27%, 25%, 30% of our patients admitted. Recently, we've gone into hopefully a more statistic-driven review of what we do. And this is what our daily board looks like in terms of patients to be seen. This was the last time, I think, this is one of the last times we had exams, and this shows all of our faculty and junior doctors at the time, many of whom become consultants. And these are the 3 most important people in emergency medicine in the Caribbean and its development. Dr. Watson, Professor William Johnson, who is the first professor of emergency medicine in the Caribbean, and Dr. Ian Sami in Trinidad. And I would just like to say a heartfelt thank you to them for all the work they've done over the years. And thank you.
Wow. Dr. King, you have outdone yourself. I was glued from start to finish. I am a little disheartened, though, that the problems of yesteryear before I was born, they're still the same problems. They're just magnified today in all the regions. Thank you for that talk. We certainly enjoyed it. And, as Dr. Wong said, it's more of the same, just sometimes bigger challenges that we have to overcome. But I'm happy we three kings have prepared us. In addition to all of those, we stand on their backs as we try to ensure that emergency medicine, improves in the Caribbean while we take on standards of care and, deal with the same problems and, try to encounter and overcome the new ones that are on our doorsteps. All right. So, having heard from our keynote speaker, Associate Professor Dr. William Burke, Dr. King, we have coming up our Director of Nursing at the University Hospital of the West Indies, who is stationed in the Emergency Medicine Division, Sister Dion P. Murphy Nedrick. She wants you to hear that she's born and bred in the parish of St. Catherine. She is a proud product of the UHWI School of Nursing from the largest batch 95. Not sure what the significance is, but okay, batch 95. She is the trainer of trainers in gender-based violence. She holds a master's in public health. She's an examiner and preceptor at the UWI School of Nursing. She's certified in industrial relations. She makes sure the nurses are paid. She is a registered midwife. She is certified in peritoneal dialysis, mass casualty management, and she's helped us manage quite a few. She is certified in palliative care, and she's also a certified HIV/AIDS counselor. Her motivating factor is mentoring young nurses into positions of seniority in the profession and to see them reciprocate the deed. The joy and pride it brings to see students who she has taught in graduate nursing school and joining the profession is very gratifying. As we know, Sister is very, 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 very good at netball, right? We tried to play doctors versus nursing, as you said, Dr. Edwards. No, we have to have a mixed group because we will tar and feather you guys. She loves to plan and organize events, and her life motto is life is filled with many opportunities. Use them wisely. Please help me welcome Sister Dion Murphy Nedrick as she presents to us on emergency nursing in Jamaica. That's, based on her perspective. All right, here we go. Over to you, Sister Nedrick.
Afternoon, everyone. Thank you, Dr. Edwards. I think you have let out some of my secrets that I didn't necessarily want everybody to know, but anyway, they're out there. I really want to thank the organizing team for having given me the opportunity to share on emergency nursing on this our Emergency Medicine Day 2026. It is indeed a pleasure for me to be discussing some aspect of emergency nursing with you. So we're looking at how it started and how it's going. So let's go. So we're looking at some history. In 1994, the Department of Surgery and Nursing Administration at the University Hospital recognized the importance of emergency nurses in achieving its goal of total quality care. They advocated for the introduction of a nursing course to address the growing needs of the emergency department. The hospital really collaborated with Bank of Nova Scotia, BNS, which provided funding for the establishment of this program. In their sponsorship, they also facilitated financially an educator, which is our Dr. Ilda Ming, to pursue the emergency nursing program at a Long Island Jewish hospital in the United States. However, in September 1996 was when we started getting things rolling. University Hospital launched a 6-month accident and emergency nursing course. It started with just 7 nurses. And those 7 nurses are really the cream of the crop. And I'll soon show you something amazing from those first 7 nurses. The program, the first of its kind in Jamaica, was created to address the needs for a specialized nursing group. If there's anybody can guess who these 2 persons are, you can type it in the chat. Dr. Edwards, please look to see who first gets it. And you have to get both of them. You can't get one without the other or you won't get the prize, right? So I'll ask Dr. Edwards to tell me when I'm finished who these 2 persons are. And by the way, this is University Hospital emergency room back in 1990 something, and I mean early 90s. So in 1996, after successful negotiation with the administration of Jackson Memorial Hospital and the Trauma Center, students were given an opportunity to spend 1 week in the emergency department at Jackson's for clinical observation at the start of the program. This became an annual occurrence until 2015, when, because of logistics and things that were not meeting the objectives of the nurses going there, it was discontinued. So we're looking at what the course outline looks like. The curriculum is actually divided in 2 strands. The first strand consists of 2 months dedicated to basically lecture, clinical experience, and in particularly in the critically ill patients in ICU. So for the first 2 months of the course, basically is spent in ICU. The second strand is 4 months, and this includes more lecture, more clinical experience, and this is mainly focused on managing patients in the emergency room. During this strand, also, students gain experience in specialized area because, you know, in the emergency room where you work, there are many specialties that comes in, and that's the excitement of working in an emergency room. You don't know what's gonna come in, and it broadens your knowledge so much that you're able to care for every single specialty. Who wouldn't want to be an emergency room nurse? So we go to areas like cardiology, obstetrics, main operating theater, pathology, and the bleeding bay. These experiences enhance emergency nurses' skills and knowledge base. In 2014, however, the course duration moved from 24 weeks to 28 weeks because in reassessment of the course, it was recognized that there needs to be more specialized area and more clinical expertise in order to facilitate all that the emergency nurse needs to do and to accomplish. So the program was in high demand, and as you can see, we've then started accommodating persons from the Cayman Islands, Barbados, St. Lucia, Antigua, St. Kitts and Nevis, Dominica, Grand Bahamas, and Barbados as well. So we're looking at what training looks like in Jamaica, and most of what I'll speak about the program itself will speak to University Hospital. So far, the University Hospital has trained 295 persons, and the Ministry of Health and Wellness in-service department has trained 235. The Ministry of Health and Wellness, however, had no training in 2016, and from 2019 to 2023, due to unavailability of a lecturer to have conducted the course. We're looking at the training by regions, and these numbers are just for the Ministry of Health and Wellness. So in Southeast, they have trained 107, Western region 41, Northern 31, and in Southern 56. We're looking at the core functions of the emergency room nurse. We're looking at triage, ACLS, administration, and monitoring of inotropes, which sometimes comes back to haunt us because then our patients stay in our emergency room forever if they're to go to the ward because they can't go to the ward being on inotropes. We're looking at suturing, male catheterization, mass casualty, intubation, application of POP, and ECGs. Those are outside of their regular nursing functions that a level 1 nurse would be doing. We want to look at some of the factors that are impacting the core function of the emergency room nurse. Overcrowding. Dr. King spoke to it, but this overcrowding impacts even the very functioning of the nurse ability to be able to carry out the core things that she used to do, like ECGs. You're looking at suturing. Suturing for the emergency use nurses now is like a thing of the past because they are so swamped and strapped doing regular nursing duties. And I mean regular bathing, feeding, and stuff like that, that a level 1 nurse can do, that it impacts the ability for them to carry out what they have been so trained to do. We look at staffing challenges. The staffing challenges are very, very overwhelming. And with the overcrowding comes the staffing challenges because the nurse is not able to carry out our core functions. A lot of time is spent doing so many other things. And there are times when in the emergency room, particularly at the university hospital, and I'm sure the other hospitals are no different, because recently Cornwall Regional had to let their voices be heard because of the nurse to patient ratio. At university, we have gone as far as 15 to 1 on some days because of what it is like. Because as Dr. King says, when the wards are full and the patients have nowhere to go, they stay in the emergency room. And we can never say, hey, we're full, we can't take anymore. We have to keep taking them, squeezing them into spaces, and just try as best as we can to do the best we can wherever we are with what we have. Skill sharing. We know that it's a teaching hospital at university, and even if it's not at university, you have medical students and students in other specialties that comes into the space that needs an access setup. They need suturing if a suturing is there. They need male catheterization. So those things also, that because these skills we have to be sharing with other persons, it's challenging for the nurses. Administrative duties. This is a tall order because we look at how much the emergency room nurse has to do. Yes, we expect that it's an emergency room nurse is going to manage the emergency room, but a lot of it is spent doing administrative duty, ordering stores. All that should really be done by somebody who is so trained to do ordering, so trained to do that kind of thing in terms of stocks and in terms of stores and stocks. You look at issue of pharmacy. If a pharmacy technician is in the department, then the nurse shouldn't have been the one to be ordering pharmacy and to be basically spending her time to do what is required, which is nursing care. So we're looking at basically where are some of these trained emergency nurses that they're not available to be in this space as CENs. At UHWI, there's one that is a director of nursing. We have 2 that has moved on to be family nurse practitioners, and 1 that is on study leave to be a family nurse practitioner. We have 3 that are clinical nurse managers. 1 is assigned in the emergency room. Unfortunately, 1 is assigned out of the area in another capacity, so she's not available to the emergency medicine division. We have 3 that have been trained, and they have gone over to be educators, understandably, because we need trained persons in the specialty to be able to teach. At Spanish Town Hospital, look at this. There's 1 on a maternity ward. There's 1 in their nursing office. That's what the distribution of the emergency nurses are like. At the Kingston Public Hospital, there is 2 that are nurse managers, 1 that is an educator, that we understand, but there's also 2 that are working as nurse manager in their specific area who are not really contributing as CENs. This is something that is an eye-opener. I looked at 1, 2, 3, 5 of our major hospitals within Jamaica, that is. And if you look at the distribution of nurses in the clinical spaces, University Hospital has 31, they have a need for 58. Spanish Town has 10, they have a need for 45. Similarly, KPH and Cornwall Regional have 14 and 8 respectively, and they also have needs for 45. Mandeville Regional has a quota of 8, and they need 28. What are the next steps? What do we want to do? We want to look at advocate for an increase in trained certified emergency nurses. We want to empower nurses to own their skills as CEN. We want to revitalize the accident and emergency special interest group within the Nurses Association. And we also want to liaison with international agencies, example, the American Emergency Nurses Association, if you look back at what training is like and the numbers that are available, so far we have trained 530 nurses in the country, right? Despite that training of 530, we now have a need of basically 150. And of that 150, between those 5 hospitals, they have 71, so we basically need 79. So in summary, the role of the emergency trained nurse is crucial within the healthcare team in the emergency room. This team works together to ensure high quality care for all patients. These specialty nurses have proven to be highly remarkable, successfully securing position across local sector and regional and international healthcare facility. And we know that generally in Jamaica, our nurses are taken. And when you're a specialist trained as an emergency room nurse, it is higher. There was a year when the hotel industry actually tapped into the skilled workforce, and at one point, 50% of a batch of nurses left shortly after they graduated, because of course it's where scarce benefits and spoils is, it's where the money is, and nobody is going to refuse not to be paid better. So we lost a lot of our nurses to the hotel industry. However, the program continues to adapt to technological advancements and evolving patient care needs in the emergency room, as evidenced by the ongoing reassessment and the changing roles of emergency nurses. This is then and now. Who can recognize the then and the now? So it's 2 prizes, and believe it or not, this is University Hospital. This is what our suture room looked like in 1997. We had a proper suture room with lights, a bed, and our sutures and everything. This is it now. No lights. So this area that should be a suture area is no longer being used for that purpose. We're using it to house patients because of what our emergency room is like. So we do not have a structured suture area within the emergency room itself. So what we have done is basically refashioned another space in another area that when we need to do suture in, we do it. But for those who never knew that A&E had this, and we had an A&E that looked like this, welcome to the then and now of our emergency room. These are some of the trained CMs that are currently in the department, and I just want to see and show you who we are. This is just a few of the 31, of course. We just have to catch them because it's a busy area. We don't have much time for photo ops, so we take the few that we have. And I just want to say thanks to a few persons who have helped me in gathering some of the information from the other facilities. Sister Bailey, educator at UHWI, Sister Bobette Evans from the Ministry of Health and Wellness in Service Unit, Mrs. Debian Cooks, Deputy Director KPH, Mrs. Candice Barrett Green from Spanish Town Hospital, Karen Wright Foster from Mandeville Regional, and Miss Barker from Cornwall Regional Hospital. Thank you for the opportunity to share. I am open to any questions at the appropriate time. And these are my last words. All nurses are made equal, but only the finest become emergency room nurses. I thank you.
Awesome, Sister Nedrick. Really, really enjoyed that talk. And thank you for bringing us down memory lane, recognizing that, yes, we used to have spaces in the emergency department at the University Hospital of the West Indies where we were not housing admitted patients. We actually had areas that we could use to do procedures in the department. I think of the past, and I mean, some of these younger doctors and nurses, they have never seen that. And I just want to thank you for at least giving us that flashback. So there was a time when, we had space to do emergency procedures and didn't have to be making do with what we had. All right, sister. So for your question, regarding those 2 stalwarts, feminine power, who are in that picture. I don't think she qualifies though, sister, because she's one too. Sister Olivia.
I don't think she should win either. I saw it, and I'm going to say no.
Sister Coombs is going to kill us.
Recently. No.
She's going to kill us, but she was first in line.
I saw
And
it.
so we have a gift for Sister Coombs because she identified Sister Yvette King and Sister Murphy, family nurse practitioner Yvette King and Sister Murphy Nedrick, from those two females in that picture of yesteryear. I just want to thank you for that presentation, Sister Nedrick. Really enjoyed it. Now, coming up just before we have a little break for persons to ask their questions and to win prizes from Massey Distributors, we're going to have a presentation by Professor Jean Williams Johnson. She's a Jamaican. She's a consultant in the emergency department. She's a consultant emergency physician. She's an educator and she's a healthcare leader. She was actively involved in the growth and strengthening of the DM, the Doctor of Medicine, Emergency Medicine program in Jamaica, contributing to training of generations. You hear me? Generations of emergency physicians and promoting excellence in clinical care, research, and medical education. She has served as program director in the emergency medicine program at the UWI and as the cross-campus university examiner for the DM in emergency medicine program. She also served as deputy dean of graduate studies in the Faculty of Medical Sciences, Mona. She currently serves as registrar of the Medical Council of Jamaica, where she continues to influence healthcare standards, professional regulation, and policy development nationally and regionally. She's the most organized person I know in life. Today, she will share insights on the DM Emergency Medicine Program in Jamaica, its evolution, achievements, challenges, and future direction. Please join me in welcoming the first professor of emergency medicine in the Caribbean, strength of a woman, Professor Jean Williams Johnson.
Okay, thank you very much for that introduction, Dr. Edwards. Yes, indeed, it has been generations of emergency medicine physician training. And of course, thank Dr. King for reminding about the work of Dr. Harold Watson and Dr. Ian Sammy as pioneers. Good day, ladies and gentlemen, colleagues, and it is indeed a privilege for me to talk to you as we celebrate emergency medicine today. Thanks so much to the organizers, especially Dr. Romaine Edwards. I'm sure you're enjoying her hosting us and enjoying her enthusiasm as she remains happy and committed and enthusiastic about emergency medicine. That's excellent. And thanks, of course, to Dr. Eric Williams and Dr. Simone French, who had some input in my talk, and my husband, Ray, who corrected a few spelling errors. Have to put him into something, right? Okay, so I'm to tell you about the emergency medicine program in Jamaica, the DM emergency medicine program. And just as an outline, we'll have a bit of discussion as to what emergency medicine is. We'll look at the program structure and evolution at Mona. I was invited to speak about Mona, but you recognize a lot of cross-campus activity. We talk about the clinical training and the various rotations that our residents had to go through before they would graduate. A little bit about research requirements, a little bit about program triumphs and graduate success. And I liked how Sister Murphy told us what the graduates are doing. So hopefully we'll be able to see that we are fulfilling our mandate for training DM doctors, and of course, future opportunities and for career development. So emergency medicine, I think we have heard from both Professor Burke and Dr. King and Sister Nedrick that we are really the specialty which manages the undifferentiated patients. Everybody comes to you with everything, and all of them are sick. They squeeze a toe and it's gonna fall off. So we have to, recognize that they're scared. So we are the first point of contact for critical illness and injury in the emergency department. And of course, our specialty will integrate things like resuscitation, diagnostics. We interviewed a doctor today who said radiology was integral in the practice of emergency medicine. So even though she wants to be a radiologist, she understands why an experience with us would be useful. And of course, this position, I have to remind the medical students that even though the department is overcrowded, the emergency department is not the last resting place, so to speak, for our patients. We really should be moving them to the wards, to home, whatever, but not the A&E. And of course, we remain a core pillar of modern healthcare systems. So why the DM in emergency medicine then? As was recognized in the 70s, it's important that the training is introduced. We used to have emergency departments where people would work, tended to be the junior persons, people who had just finished and were just working before they moved on. But it was important that we taught our residents high life-saving interventions. There was a need for that broad clinical exposure. Remember, we spoke about the undifferentiated patients, so they need to think widely when our patients come to us. Leadership in crisis. Dr. King was good with showing us all those vivid pictures of the various mishaps that can happen in our region, hurricane to volcano ash, really something. Our doctors need to understand disaster response and who to see first, different types of triage, and of course, we remain essential to health system resilience. The program started in 1990 in Barbados. As you heard, we're very happy for that. Dr. Rana Naidu was the pioneer who introduced emergency medicine alongside Professor Sir Errol Waldron in Barbados. Professor Lenworth Jacobs, he was actually one of the persons who examined us when we had that first graduating exam. And the program was based on the family medicine rotation system and those strong links with Hartford Hospital. So we decided, or we really, as was mentioned before, Professor Archibald MacDonald recognized the need for a similar training program here at Mona, and assisted with Dr. Charlton Colley, who was double boarded in, I think, pulmonology and emergency medicine. The program started here at Mona in 1997, and it was launched with 7 of us residents. I think most of us are pretty much still practicing emergency medicine. We're here at Mona, in Cayman and at KPH. So this marked the beginning of a robust training pathway. We had keen faculty at the time. We evolved, and I was in charge of the program from 2005 to 2021, but I would never deign to suggest that I ran the program by myself. As you know, the support is always extremely important, and I had quite keen and enthusiastic faculty working alongside. The program director is currently Dr. Simone French. She took up the baton in 2021. Tell a little bit about the program, what are the requirements and the selection process. The candidates must hold an MBBS degree or equivalent. They must be fully registered with the Medical Council of Jamaica. Very important. If they're not registered with the Medical Council and the powers that be find out, the police can come and sort that out, right? We think some clinical experience is encouraged. We have had physicians who have been working in the A&E and they recognize that, yes, this is what I want to do. Or they came in thinking they want to do emergency medicine and they said, well, can't deal with the night duty, whatever. So I think in Barbados, they have to work for a few months before they can actually start the program formally. So we do have a rigorous interview process to ensure the candidate really wants to do emergency medicine and their suitability for the specialty. In terms of the academic framework, as Dr. King said, we began initially with a program that would see the award of the MSc after 3 years, and then after a further year, a casebook or research option would be explored and the resident would have a DM degree. And then it transitioned to a 4-year DM program where we realized that importance for the applied basic sciences probably wasn't being sufficiently examined. You know, somebody would come in with a wound over the wrist, for instance, and they needed to know what arteries what tendons, what would you expect when you examine the patient, and recognize the importance of applied basic sciences. And then we have 2 years to the DM part, 2 years to DM part 1, and then the exam, and then the final DM part 2, which will another 2 years, and candidates would have to do a bit of research and do some case reports before they would graduate with that degree. As part of the academic framework, an overseas elective experience was encouraged. When we started, it was almost mandatory because we felt Dr. Prof. McDonald at the time felt it was important that we see emergency medicine in other areas to see international best practices. And what we recognized, the places that we went and what we saw, we were pretty much doing okay. We were up to international standards. And the hospitals that we went to, or candidates are still going to, are listed there. And happily, there are also chances for regional elective experiences. We have had candidates from Mona going to Barbados to experience their EMS, which is one of the first-class ones in the region. And in Trinidad, there's actually had a developed pediatric emergency room where our candidates have gone for that sort of elective time. So a bit more about the program objectives. So we want to train for clinical excellence in acute care, recognizing that the patients who come to us, a lot of them are in extremis. So we need to recognize that they need to be acted on right away, not like that patient who got the gunshot and went home with it. And the doctor came the next day that Dr. King told us about. It was interesting to hear that. We want to train leaders in emergency systems. As we progress through life, we have to recognize succession planning. We promote research and evidence-based practice of emergency medicine. And of course, all of this leads to strengthening Caribbean emergency care capacity, recognizing that the university gives us a mandate not just to train for Mona, but to train for the region. So academic components are important, and that is done via twice weekly protected class time, when there are case presentations that will discuss patient management. There's journal club, and when the residents are in the department, there are morbidity and mortality meetings. Those academic sessions continue. And of course, core competencies, which includes simulation training, advanced trauma and advanced cardiac life support training is important. Each time the candidates are assessed, we ask, have you done this? And of course, procedural skills are part of the whole competency that we expect. Ultrasound, as you know, is sort of becoming the stethoscope of medicine, I gather, and other things like test tube placements, etc. The skills have to be, there's a whole list of things that we expect our candidates to learn. There's a comprehensive rotation structure in order to facilitate the DM training. There's a core emergency department rotation when the candidates spend 6 months per year, at least 6 months, in the accident and emergency department. And I must mention 2 innovations which weren't there at the start of the program. The training week, which Dr. French leads, where we introduce our first-year residents to various emergency department systems and procedures, which they always say they appreciate and enjoy. And we recognize that a few of the candidates, when they were finished and they were off to work by themselves in the various hospitals, the complaint was they just wanted to see patients and they were just working without actually recognizing there was a need for them to be administrators of the departments as well. And Dr. French again has introduced this administrative elective month where our 4th years spend some time learning how to run an emergency department. And I thought that was something that needed to be mentioned. Well done. And of course, as was mentioned by Dr. King, we have the various specialty rotations, which range from 3 months to as short as 2 weeks, depending on what we think will be important for our residents, and the list is there. The training facilities, of course, are important. The primary training does occur at the University Hospital of the West Indies in the emergency department and the various rotations, but training also occurs at the various regional hospitals. Gratitude for that. And these hospitals have been accredited for emergency medicine specialty training, talking particularly about the Spanish Town Hospital and the Kingston Public Hospital. And I think it was about 2010, we had split off to the Bahamas, and we had to go there as well to accredit their emergency department for emergency specialty training. So we have a multifaceted assessment methodology. The emergency medicine program is supervised primarily by the Specialty Board of Emergency Medicine in the Faculty of Medical Sciences. This was in 2018 that we managed to convince surgery to allow us to go our own way to have our own specialty board. The residents are assigned supervisors, and we usually try to have 3 to 4 residents per supervisor. And there's continuous assessment going on. They're supposed to be putting their activities into their logbook so that we can assess their procedural competency. There are written exams, as I mentioned before. The examinations occur at 2 stages, DM1 after 2 years, DM2 after 2 years. And apart from the written exams, there's an oral and an OSCE. And the research project has to be presented before they can do the DM Part 2. And publication is encouraged because it is important that when residents do the research, the information that they have gleaned is shared with the fraternity. I should tell you that there's cross-campus interaction through the Regional Training College of Emergency Medicine, which was started primarily, I think, on the initiative of Dr. John Paul, who is currently serving as a university examiner. And we have cross-campus exams where the examiners get together and examine the candidates from the various campuses twice per year. This was the exam, I think it was in 2023, I think, when persons came. And as you can see, everybody's looking fine and happy. I'm suspecting it meant we had a good outcome. And I'm sure if you look closely, you can recognize persons in this picture. Research challenges remain for the program. I think some of them we have tried to overcome. There's difficulty with accessing records, patient records sometimes, even with the electronic medical record system that we have here, is not terribly user-friendly as yet. Research assistants, there was an effort to get a research assistant, but that didn't last. And of course, funding always being off for research. We had some solutions when Professor Philip Levy, back, I think it was in about 2007, he managed to get some research grants, and 11 of our residents went off to Detroit, Prof. Burke's hospital, to learn research methodology, and I think they benefited from that. And some of them are actually part of our faculty now. And now there's structured teaching our research methods as part of the program. I think Dr. Dasgupta leads that charge. I was told that I must mention that we have been fairly successful in terms of clinical trials, the CRASH-2 study in particular, where we were part of the investigation. We were one of the investigative sites for the introduction of tranexamic acid that is now used for patients who suffer significant hemorrhage, CRASH-2, recognizing that once this drug is administered within 3 hours, the outcome is the most favorable for the patients. So our program Triumph and Successes, I thought you'd like to know the images that I have on the screen really relate to all our faculty right now, but it about anybody. Dr. French is our leading sonographer, having been trained in the Michener Institute in Canada. Dr. Edwards is our sepsis guru, for want of a better word. She's did her research in sepsis and continues to lead in terms of knowledge in that area. Dr. Rhonda Hudson, leader of sports medicine. She was actually the president of the Jamaica Association of Sports Medicine for the last, I think, 4 years, and she continues on that executive. And she's an expert sexual assault examiner and trainer. We're going to hear from her in a while, I gather. Also, Dr. French. Dr. Nadia Thompson-Newell is fellowship trained in pediatric emergency medicine and simulation. We're happy to have her on board as she came back from sick kids. She has come with a wealth of knowledge and enthusiasm to join our faculty. Dr. Jason Eiffel, one of the younger members of our team, he is our stroke team leader, and the diploma program, which is a spin-off of a DM emergency medicine program, started in Trinidad, and the Trinidad faculty had been kind enough to allow us to kind of piggyback on their program, and Dr. Eiffel leads that charge. And of course, Dr. Eric Williams, Dr. Shubha Dasgupta, our trauma management guru, with Dr. Gurus S, with Dr. Dasgupta being our lead in pre-hospital emergency medicine training. So we're happy that this has happened. In terms of graduate outcomes and leadership roles, we have over 70 graduates from 2001 to 2026. And we have 4 of our graduates who are leaders in our Ministry of Health here in Jamaica, and we are quite happy and proud of them. Dr. Jacqueline Bisesa McKenzie served as the Chief Medical Officer of the country, has had quite a challenging job, led us through COVID and through hurricane, and we're always happy and willing to support as best we can. Dr. Nicole Dawkins Wright, who is in charge of emergency management and special projects. Dr. Janice Miller, in charge of emergency medicine systems, and she's in charge of all our A&Es. They have regular meetings to see that the departments are run as into international standards. And Dr. Edward Horton, who does special projects for the ministry. So we salute them, and we're happy that graduates are contributing that way. In terms of Jamaica, I think we have over 39 graduates throughout the region, almost every major hospital, and recently hospitals like Princess Margaret, Lionel Town, Linstead have graduates, and we're happy for this. As I said, we do have regional involvement. Lots of graduates are employed across the Caribbean. Cayman Islands actually has 16 graduates in their A&E, I was told, which I think is commendable. I think we should all be striving towards an emergency room where most of the doctors our consultants are attending, are DM trained, and then other numbers are there. And interestingly, one of our graduates has gone off to the UK to continue the practice. So in terms of career paths for graduates of the DM program, the clinical and academic roles, of course, are paramount. Various consultant roles in the various hospitals, academic teaching positions, especially if they align with the University of the West Indies, and a few of our doctors have hospital leadership roles, being SMOs or heads of departments, heads of emergency departments in particular. And of course, public health and international opportunities will always be there. Training in disaster management, very important for our region, our country. And in that, international collaborative opportunities are certainly available. We have links with the American College. We have links are trying to make links with the global emergency department there in Detroit Receiving Hospital. So there are opportunities for our graduates who want to explore that way. I can't end the talk about our DM program without telling you a little bit about the Jamaica Emergency Medicine Association. The JEMA, as we like to call it, was actually started in, I think it was 1998, with the first group of DM residents. We actually started as a resident organization, and then in 2001, when the first batch graduated, we took out the resident out of it. If you look very carefully, I'm sure some of you can recognize yourselves. There's Prof. MacDonald, who allowed us to come to his home for a get-together. And here is Professor Judith Tintinelli. If you remember, she was our first guest speaker in our when we had our annual landmark yearly conferences. And I think she came back again 10 years after that, when we had reached 10 years of existence. And I recognize here's Dr. Naidu, and here Dr. Singh with hair, and there's Dr. French, Dr. sorry, Professor MacDonald, who was important, Professor McCartney, Dr. East, and here is our head of department, Dr. Hudson, I'm sure, and here's our CMO. I hope you recognize that we have progressed. So Dr. Curtin Espinosa Campbell is actually head of a team now, and she's encouraging regeneration and professional development within the specialty under the ambit of the Jamaica Emergency Medicine Association. And listed are the names of the persons who are there supporting as members of her executive. And we're happy for that because there's a bit of a hiatus because of the COVID. So well done to them. And we look forward to getting a group picture to put next time or whoever does this again. So future directions and strategic growth for the emergency medicine program. I think areas of focus continue to be things like integrating simulation medicine into the training, enhancing research output, and continuing to expand our international and regional partnerships, which will, of course, help to solidify the program. So I thank you very much for giving me this opportunity to speak about a specialty, which I think is the very best one to do. I've always said that. And just to share this Ralph Waldo Emerson's quote, which some of you recognize, this is what Professor MacDonald brought to the table, introduced us to when we started the program back in 1997. Thank you very much. And over to you, Dr. Edwards. Okay.
Thank you very much, Professor Jean Williams Johnson, for such an encouraging talk. Clearly, there are lots of scope for us to grow in emergency medicine, and there are uncharted territories that lots of us are exploring. And it makes the rest of those that are coming up look up to us, and even so chart their own path. Simulation medicine with Dr. Thompson was one that we didn't see coming. And, she will outline such. But as you said, there are paths that we can actually go on that persons have, broken the ceiling, administrative and otherwise. And there are other paths that persons are actually making so that, persons have the opportunity to follow on or to create their own avenues in emergency medicine. All right, so we are at the segment where we take a small break from the talks and we give you a chance to win prizes. All right, so far, Sister Coombs has won her gift, and we're going to ask if there are any questions in the YouTube chat that we could take them at this time. And if there are none, I have my technical team combing through the chat to see if there are any questions. And I'm going to also ask our presenters that if they can look in the chat and answer accordingly. However, we have our sponsors, Massey Distribution through Miss Natalie Robinson et al. Online, and we're going to have a presentation by Mr. Spencer Anderson from American Hospital Supplies. He's going to detail us on the iStat BNP cartridges and any other equipment that they have available to us, as well as they are going to ask questions, and the first persons that can answer, I have a few here if they need any help. I, was listening, taking notes, so that persons can win surprises and baskets from Massey Distribution. Over to you, Mr. Anderson, if you're on.
I am on, Dr. Edwards. Thank you very much for that introduction. So I represent American Hospital Supply, and we are the distributors for the iStat, which I believe you are all familiar with. The iStat system has become an essential tool in emergency medicine, providing rapid diagnostic support through cartridges, such as the CG4 cartridge for lactate and blood gas analysis in septic and critically ill patients, which I'm sure Dr. Edwards is a big fan of. Chem8 cartridges for rapid electrolyte, renal function, and metabolic assessment. Troponin cartridges for cardiac injury evaluation and acute coronary syndrome management. These cartridges have significantly improved patient management by reducing turnaround time and allowing immediate clinical decisions in critically ill patients. Let's see. There we go. In the A&E setting, one of the most common and challenging presentations is shortness of breath. Clinically, it is often difficult to immediately determine whether symptoms are due to acute heart failure, COPD exacerbation, pneumonia, asthma, pulmonary embolism, or other causes. The BNP test is a diagnostic tool used in modern healthcare settings to assist clinicians in the rapid assessment of patients with suspected heart failure and other cardiac conditions. Now, being familiar with BNP, the iStat has a test available. The iStat BNP cartridge is an important addition to the current point of care testing capabilities within the A&E department. The BNP cartridge provides rapid objective data that can assist physicians in narrowing the diagnosis quickly and confidently. One of the major advantages of the iStat BNP cartridge is speed. Results can be obtained in approximately 10 minutes directly at the patient bedside or within a lab using whole blood samples, where the traditional laboratory testing can sometimes take hours. This rapid turnaround supports faster triage, earlier treatment initiation, and improved patient flow within the emergency department. Adding BNP testing would further strengthen the emergency department's ability to manage cardiac and critically ill patients comprehensively on a single platform. The BNP cartridge would complement the existing cartridges in several important ways. First, it enhances cardiac assessment, while troponin assists with identifying myocardial injury and infarction. BNP focuses on cardiac failure and ventricular strain. Together, they provide a broader picture of the patient's cardiovascular status. Second, it supports rapid clinical decision-making. Elevated BNP levels can guide the need for diuretics, cardiac imaging, admission, or referral to cardiology, while low BNP levels may help exclude heart failure and reduce unnecessary admissions. Third, it improves patient flow and emergency department efficiency. Faster diagnosis means reduced delays in treatment and more appropriate use of hospital resources. And fourth, it promotes improved patient outcomes. Early recognition and treatment of acute heart failure are associated with reduced morbidity, mortality, and hospital length of stay. Another important consideration is ease of use. Since the department is already familiar with the iStat analyzer, introducing the BNP cartridge would require minimal operational adjustment. Staff are already trained on the system, making implementation smooth and practical. So, from a clinical standpoint, BNP testing is particularly valuable for acute shortness of breath evaluation, congestive heart failure diagnosis and monitoring, risk stratification in cardiac patients, monitoring response to treatment, identifying fluid overload in critically ill patients. BNP testing would further enhance rapid bedside diagnostics, support more accurate cardiac assessment, improve emergency workflow, and ultimately contribute to better patient care. Thank you very much.
Awesome. Thank you very much, Mr. Anderson, for reminding us how important BNP point of care testing is. And I am going to select that as the first, well, it will be for the second gift. First gift went to Sister Coombs. Second gift is I want someone to tell me what the BNP landmark study, what does BN&P, that landmark study, what are what is the name of that study, that BNP landmark study that affords us to use BNP for acute dyspnea in the ED? That's one question. To win baskets from Massey distributors. The second question will be, when was the first cohort of emergency medicine nurses? When did they have the first cohort of emergency medicine nurses, and how many nurses there were? And the third question is, when was the emergency medicine program started in the Caribbean? When was the first emergency medicine postgraduate course started in the Caribbean, and where? So we are asking you to put those answers in the YouTube chat, and from that we will select our prize winners, courtesy of Massey distributors. So I want to thank Mr. Anderson again for reminding us how important point of care is. And I will check with my technical team to see who are the winners of those prizes. And it's a pity I am hosting, so I don't get to win a prize. The baskets are lovely, guys. All right. So moving on, because we started a little late, we're going to move on to our next talk by Dr. Mara Hosang. Dr. Mara Hosang is a Christian, she made sure underlining, a Christian pediatric emergency physician who loves working with children and is a child at heart. After completing her DM in pediatrics in 2010, she became the senior resident and subsequently consultant pediatrician in 2013 at the Bustamante Hospital for Children in the Accident and Emergency Department. She completed clinical fellowships in pediatric emergency medicine and pediatric emergency point of care ultrasound at the University of Toronto, Canada in 2015. She is excited to see the field of PEM growing in Jamaica as more physicians become trained. She has an interest in accident prevention and resuscitation and is certified with the American Heart Association, BLS, Pediatric Advanced Life Support, as well as PAHO WHO Mass Casualty instructor. She's an instructor. When she's not working, which, I don't suppose that's a lot, but when she's not working, she enjoys spending time with family, friends, traveling, swimming, and singing. Without further ado, I'd like to hand over to Dr. Mara Hosang to present to us on pediatric emergency medicine.
Hi, good afternoon, everyone. I'm just having some internet issues here, so give me a moment and I'll have my slides up, please.
Okay, in the meantime, we're just gonna look in the chat to see who are the lucky winners of these prizes, courtesy of Massey Distribution.
Let's try again.
Yeah.
Relax. Okay. Go to your thing and join the new team. Hello.
All right, so we have a winner. of the second prize. BNP, that landmark study that now afford us to figure out in terms of acute dyspnea based on the BNP test, breathing not properly. So Dr. Matthew Blackwood, you have won yourself a lovely basket from Massey Distributors. And for our third prize, Price Waterhouse endorsed. Our third prize goes to what year was the first cohort of emergency medicine nurses started in Jamaica, and how many nurses? So we have, she doesn't qualify. Sister Yvette King. Okay, all right. I see you, sister, one of the founding members of emergency medicine. So Sister King wins the third prize.
She's talking about some prize.
And for the third prize, when and where was the first emergency medicine postgraduate program started in the Caribbean, and where?
Just highlight that.
That prize goes to legendarily 1192.
How much time was it supposed to be?
The first prize, the third prize, the fourth prize, sorry, goes to legendarily 2281.
Yeah.
You have to identify yourself, or it goes to the moderator. Just kidding. So the first program was in Barbados in 1990. So thank you to all the persons who are listening. We actually have a very bright audience. They quickly identified all the questions and had correct answers. Okay. All right, so on to Dr. Hosang. All right, Dr. Hosang, now that you hear me, you can go ahead.
Okay, great. So hi, good afternoon, everyone. Today, I just wanted to use the opportunity to say thanks for the organizers for giving me the opportunity to share and just bring to our attention something that we see regularly in the emergency department here at Bustamante Hospital for Children. So upper airway obstruction. So respiratory concerns account for the most frequent ER visits in the pediatric population. And so it's important for us to be able to identify and manage potential life-threatening conditions in a timely manner, because we know children can rapidly progress from just having mild respiratory distress to failure and then cardiopulmonary arrest. And the outcome thereafter is usually very poor. So respiratory problems can be categorized into 4 broad categories based on the American Heart Association classification. We're looking at upper airway obstruction, lower airway obstruction, lung tissue disease, and disordered control of breathing. Now, with upper airway obstruction, it's defined as having blockage or occlusion of any part of the airway that's located above the thoracic inlet, which means the nose, the pharynx, and the larynx. Causes usually are because of some kind of swelling, inflammation, foreign bodies, or infection, or you might have soft tissue swelling, which you see a lot of T's and A's, tonsils, and enlarged adenoids. Also, secretions, blood, and vomitus. But children are just generally prone to upper airway obstruction because of their anatomy. As we know, compared to the adults, it tends to be smaller. It's more narrow, it's funnel shaped, the epiglottis is U-shaped, tends to be more floppy. Likewise, the trachea isn't as rigid and it's shorter. And the most narrow portion is actually below the larynx. The other thing is that kids tend to have big heads. And because of that, You might have an issue with flexion of the neck causing kinking of the airway. And this is just a normal part of development for them as they have poor head control. And as they get older, they're better able to control their heads. But also when you think about the patient now who has depressed sensorium and is supine, or you're examining him on the bed, you might need to use some adjuncts to get them in this neutral sniffing position as demonstrated. Now, how do we approach a child who has upper airway obstruction? Well, guess what? It's the way we approach everything in pediatric emergency medicine, a systematic approach. First, we'll do the initial impression where we look at our pediatric assessment triangle. Then we move from there to our primary assessment, secondary assessment, diagnostics, and then disposition. And I strongly recommend for all emergency doctors or room doctors to do pediatric advanced life support. All right, so the initial impression, the aim here is just to identify if there's a life-threatening emergency, something that we need to intervene with quickly. And how we do this, we look at the appearance of the child, the work of breathing, and the circulation. And this is done with the child being a little away from us. You do not touch the child. So you're observing and listening. So for their parents, we're looking at the tone, how interactive they are with the parents, the staff. Are they consolable? Are they alert, looking around and interested in the environment, or do they just have a blank gaze? Is there any crying, any speech? Are they talking to you? What is the work of breathing? What position or posture have they taken? Are they in this tripod position where they're leaning forward to keep the airways open? Or are you seeing the use of accessory muscles, intercostal, subcostal retractions? Are you hearing any sounds like high-pitched noises suggesting airway obstruction, stridor, or you might be hearing wheezes suggesting lower airway obstruction? And then, of course, you just look at the color of the child. Are they looking pale? Are they looking mottled or cyanosed? Right? So this is giving us an idea of what the circulation is like. So when you put it all together, just quickly assessing the child, you'll determine if they have an acute life-threatening condition. And if you identify this, you need to intervene immediately. You're not a one-man show, so you always call for help. In emergency department, it's unlikely that you're going to be the only person there. Position the airway, try and open it up because we described some of the challenges that we have with the pediatric airway. Oxygenate and ventilate as needed, and CPR if indicated. And while all of this is going on, your colleagues would come with all the monitors to help you to get some vitals. If there's no life-threatening condition, then you can continue with your assessment. And here you get a chance to touch the patient. So you're going to do your primary assessment, which is going from airway, B, C, D, E, looking at the airway. Is it patent and maintainable? The breathing, circulation, disability, and then exposure for any signs of trauma, bleeding, rashes, etc. Once that's done, we go into our more detailed history. In real life, you actually will be getting the history as you go along if you have a very ill patient. And but again, systematic, so you don't forget to get it. And then you do a reassessment of your interventions and ultimately do whatever diagnostics are required and you dispose of your patients. So foreign body airway obstruction. The incidence of non-fatal choking, which is equivalent, is unknown because most of it is transient and patients don't come to the hospital. But for the ones who do, the majority of them are due to food. And the food of choice here would be small round objects. For example, the hot dogs, the carrot sticks, the hard candy, the grapes. In our setting, guinea seeds. Non-food items, coins, marbles, balloons, we see pins. Most of what's here we've seen. And of course, some of them you don't know what's the cause. Its incidence is greatest among infants, and the choking hazards, more than 75% of them are occurring in children who are less than 3 years old, and there's no sex predilection. So it's reported that foreign body airway obstruction is the 4th leading cause of accidental death in children in the US. And as we said, food is the #1 cause on round foods, and the main culprit is hot dogs. So advice for our parents is that if you're giving your child hot dogs, cut it longitudinally and not cross-sectionally, where that round shape, it's more likely to obstruct the airways. Hard candies, nuts, grapes, you need to dice them and cut them really small for them. Non-food items, the number one fatal killer is latex balloons. And we know our children like to put it in the mouth after the parties and do the scripts, and then they actually swallow it and it obstructs the airway. It can be very fatal. So they're prone to foreign body airway obstruction, again, structurally because the airway is small and narrow, but also their cough reflex is not as strong and they don't generate as enough force as an adult to likely dislodge the foreign body, hence the maneuvers we use. And also children commonly put things in their mouth just as they learn and explore about the environment, but also for older children, sometimes it's just a habit. They like to chew on pen tops or something like that. In terms of the history, what history are you going to get for a child who has been choking? So likely a sudden onset of respiratory symptoms with cough. They may have stridor or wheezing. The parents may be able to tell you that, yes, the child was eating prior to that, or they were playing with some toys or small objects, or maybe they even saw the foreign body in the mouth. And the child might have some intellectual or musculoskeletal disabilities that predispose them to putting random things in their mouth. But however, once you have a history of choking and coughing, you need to have a high index of suspicion of a foreign body air obstruction or a potential aspiration. So examination-wise, what you're looking out for, increased work of breathing, so increased respiratory effort, the stride or the hoarseness, diminished breath sounds on auscultation. They may even be absent if it has gone down into the mainstem bronchus. And you have unilateral wheezing. One of the key things, if you're suspecting a foreign body, is that you need to look in the mouth. You need to look at the pharynx, because if the foreign body is there and it's retrievable, it's fine for you to do so. However, you should not do a blind sweep. It also gives you the opportunity to identify other causes of stridor. For example, a retropharyngeal abscess for that patient, or a foreign body, as we said, or something else is there. In terms of what you do with the patient, if you assess it's a mild obstruction and the child is still coughing, allow them to cough and try to clear the foreign body themselves. However, if it's severe, you're hearing the high-pitched sounds, they're not breathing well, they're not having good air exchange, they're holding their neck, showing the international sign of choking, then you might need to go to your algorithm. All right, so what is there to see? If there's an infant, as usual, you need to identify that the scene is safe and then assess the severity. If you decided that it's a severe obstruction and the child is still responsive because you would have activated your emergency response system already, then you're going to give 5 back blows followed by 5 chest thrusts. You're going to repeat this cycle until the foreign body expelled or the infant becomes unresponsive. Now, if the object is expelled, you can take it out of the mouth. If not, then you continue doing the cycle until the child becomes unresponsive or someone who can manage an advanced airway is present. So what I wanted to highlight here is that there's been an update in the American Heart Association guidelines 2025. So for the chest thrust, you're now asked to use the heel of the hand and no longer the 2 fingers. So that's a change. For the older child, you've identified that it's a severe obstruction. They're still responsive. The new updates suggest that you give them 5 back blows followed by 5 abdominal thrusts. And you continue to repeat this until, again, the object is expelled or the child becomes unresponsive. So the addition of the back blows is new for the 2025 guidelines. If your patient was stable, then you would have had a chance to do some investigations, for example, radiographs, AP and lateral neck. The x-rays might help you to confirm that there is a foreign body. However, it does not exclude a foreign body obstruction, especially if the history is strongly suggestive. The reason being that many of the foreign bodies are radiolucent, but you might see secondary signs, for example, hypopharyngeal overdistension or soft tissue swelling. The chest x-rays might show unilateral hyperinflation or atelectasis, maybe even shifting of the mediastinum. as demonstrated the hyperinflation in the x-rays on the side. Or you might actually see the foreign body, and this is a regular x-ray that we see in the department at least once a week. In this case, the foreign body was actually not in the trachea, but in the esophagus. So just to bring it home to show it's something to see, like last year, we actually had a 4-year-old girl who presented to the department with a history of choking on a guinea seed. The family stated that they were just 5 minutes away from the hospital. So while they were hitting on her back, they were rushing with her to the hospital. When she came in, she was actively choking. She had no obvious breaths, not seeming to take any obvious breaths. There was bloody liquid coming from her nose and mouth, and her lips were blue, but she was still able to respond to command. Here, acute life-threatening condition. And so the team got there quickly and started to institute management, which included the back blows and the abdominal thrust, because it's a bigger child. The guinea seed thankfully was dislodged, it was displaced and was removed from her mouth. And she was commenced on oxygen therapy. Within a few minutes, she was a new child. No distress, she was alert and telling us about the incident. Significant findings, however, is that she was still hypoxic and had to be maintained on 5 liters of oxygen. And they saw some bruising to her tonsil. She was ultimately admitted to ENT after receiving steroids and analgesia and was subsequently discharged in 48 hours. Just earlier in the month, we had a 6-year-old who had reported that he was choking on a pen cover. His family members didn't take him serious. They gave him a pat on the back and sent him back to bed. However, he later complained that he was having difficulty breathing and his chest was hurting. So they brought him into the emergency department. This was probably about 3 hours after the incident. At that time, when he was seen at triage, his rest rate was 48. He was sitting at 89 to 90. And when they auscultated, his breath sounds were decreased on the right. So he was commenced on oxygen. Just from the history, high index of suspicion. So we thought he likely would have aspirated or was choking on the pen top, although nobody actually saw it. He was admitted to ENT. Unfortunately, had failed bronchoscopy and had to be admitted to ICU and ultimately had thoracotomy done to remove the foreign body. So his x-rays initially not very impressive, but ultimately they did get the foreign body out and he was reviewed last week and is doing well. So this is an everyday. And just to say, yesterday we had a 6-month-old who came in. The mom said the child was choking. She didn't witness it. Opened the mouth and she saw something that looked like a ring. She ran with the child, the infant. When she came, the child actually vomited in triage and there came the ring. So it's every day up till yesterday we saw it. So it's something that is very relevant and we need to know what to do. So the other thing that is really scary for patients, but is not as concerning for us, but we need to know is croup. It's one of the most common causes of upper airway obstruction in younger children, and it's usually due to a viral illness. The age range is usually 6 months to 3 years. And in terms of the organism that's been implicated mostly is the parainfluenza virus and more type 1, but other viruses can cause it as well. The clinical features, usually the parents will give a history of the child having some low-grade fever, maybe runny nose or throat, and then ultimately early in the morning or late at night, they start this barking cough. For us, we describe it as your sand dog, but others might describe it as a sea-like bark. The child has this high-pitched stridor, the voice might get hoarse, and they're seeing signs of increased work of breathing and respiratory distress. So they usually run out at 2 o'clock in the morning, frantic in the A&E, help, 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 help. Luckily, less than 1% of them have life-threatening symptoms. However, we need to note that not because it's an infant, it must be croup. If it's outside of the age range, or if you see red flags, for example, a toxic appearance or drooling, or the child has dysphagia, you need to think of other diagnoses. For example, foreign body ingestion or a differential abscess or something along those lines. So the differential diagnosis is there. In terms of how we manage it, Always try and keep the child as comfortable as possible, and the management is based on the severity. Factors we look at include the extent of the cough, the barking cough, the stridor, how distressed are they in terms of seeing recessions, how agitated, and their cyanosis. So principles, as we mentioned before, you need to go through your ABCs. And steroids. All cases must get steroids. Oral route is a preferred route, and DEX is a preferred steroid. However, you can give it IM or nebulized corticosteroids if oral can't be tolerated or is contraindicated. Children usually will improve within 2 to 3 hours, and the symptoms improvement should last for about 24 to 48 hours. The importance of giving DEX is that it reduces the need for epinephrine nibs. It reduces their ED time. It reduces their repeat visits. It reduces the need for admission. So DEX. If they have moderate to severe croup, you should also nebulize them in addition to giving the DEX with epinephrine. You can use racemic epinephrine, but it's not readily available. So regular L-levo epinephrine, 5 mils of the 1 in 1,000 solution can be used to nebulize the patients. There's usually no role for short-acting beta-2 agonists or antibiotics. And studies have shown that helium oxygen mixtures can be used, but it's not readily available and really doesn't show much improvement compared to standard practice, so it's not routinely recommended. So there's an algorithm in terms of how to treat the patients in the ED, depending on their severity, but the summary is, if it's a mild case, PO-DEX and home. Moderate, PO-DEX, observe. If they no longer have stridor at rest after 2 to 4 hours, you can allow them home with advice, and they're saturating well, of course. If they're severe and you needed to give epinephrine, you would have given DEX. They need to be in the ED for at least 2 hours, ideally 4 hours, to ensure that they're not having any stridor at rest and they're comfortable. If they had the signs of impending respiratory failure, then nebulization with epinephrine would be Q 15 minutes as needed, plus their DEX, and these children would need to stay for observation. If you're in a peripheral hospital, once you see that, you can start making preparations to transfer the patient. So that the parents don't come back to you in 48 hours in the middle of the night, stressed again, just give them good advice. It will continue. It usually will resolve in a few days, and you can share literature with them. If the patients are not resolved after 4 hours, again, admission is required, and they might need ICU admission if they require multiple epinephrine nebulizations. So just to throw in another cause of upper airway obstruction that you must not miss is epiglottitis. The incidence of this has decreased significantly over the years because of vaccination. It usually would affect children between the age of 2 and 7. And the key thing here to look out for is the 4 Ds: the dysphagia, the dysphonia, the drooling, and they're very distressed. And they take up that tripod positioning. These children you handle with children's gloves as gentle as possible. You advise your airway team, if you have on your ICU, your ENT staff, because these children likely might need to go to theater for their airway to be secured. If you need to do any intervention, these are the ones you're going to find in the MLAW to do, so you can put in an IV without any stress. Many times these patients will go to theater where they have better control of their airway to put in the access and start all of that resuscitation. So key things to look out for: the tripod positioning, the stridor, the muffled sounds. Right, and I mentioned that. And X-rays, when they're stable, the classic sign is a thumb sign, highlighted with the cartoon here, and the radiograph with the arrow shows exactly what the thumb sign looks like. All right, so your stable patients, try not to compromise their airway. The unstable ones, call for help immediately because they might need a surgical airway from those who are able to do it. Just another one to throw in, last X-ray, retropharyngeal abscess. It might be another reason why you're hearing stridor, because they have widening of the retropharyngeal space, pressing on the airway. So you have a narrowing of the airway there. So thanks very much. I'll take any questions at the appropriate time.
Wow, thank you very much, Dr. Husang, for reminding us of those emergent causes of airway obstruction, as well as to update us on the foreign body airway guidelines, American Heart Association. And I think that will form one of our questions. So we have actually 6 prizes, thanks to Massey Distribution. I will let you know what that question is. Dr. Husang, you can actually message me that question so I can ask the audience for an opportunity to win 2 more prizes, courtesy of Massey Distribution. Okay, so now that we have been edified on some emergency causes of airway obstruction, we are ready for Dr. Simone French as she outlines to us point of care, ultrasound, and emergency medicine. So Dr. Simone French is a Jamaican emergency physician, sonographer, educator, and researcher with more than 2 decades of leadership in emergency medicine, ultrasound education, and healthcare quality improvement in the Caribbean. She serves as senior lecturer and program director for the Doctor of Medicine Emergency Medicine program at the University of the West Indies, Mona. She has held several senior leadership roles, a visionary if you ask me, including medical director of the Emergency Medicine Division at the University Hospital of the West Indies. She's known for her work in emergency department operations, triage systems, and point of care ultrasound POCUS. She's certified in ISO 9001, which she dragged me to do too, and ISO 22870 quality systems, and has led national and institutional initiatives in emergency care, disaster preparedness, and point of care testing. Her research has focused on key areas in emergency medicine practice and systems improvement, including implementation of the ESI, the Emergency Severity Index, in Jamaica, ultrasound in emergency medicine, physician burnout, and emergency care systems, strengthening low and middle income countries. She has authored and co-authored several peer-reviewed publications and has contributed to a book chapter in the 9th edition of Tintinalli's Emergency Medicine. If you know Dr. French, she's a passionate educator, and she has pioneered formal ultrasound training within postgraduate emergency medicine education at UWI and has trained generations of physicians, nurses, and emergency medicine residents across the region. Her work reflects a strong commitment to clinical excellence, innovation, mentorship, and the advancement of emergency medicine and healthcare systems throughout the Caribbean and beyond. I have the pleasure of welcoming Dr. Simone French to give us a talk on point of care ultrasound in emergency care, the past, the present, and we're ready for the future. Over to you, Dr. French.
Good afternoon, Dr. Edwards, and good afternoon to everyone who is online listening. Thanks very much to the organizers, and by the organizers, I'm predominantly speaking of my, I think Dr. Edwards is actually my real boss in real life. She gets me to do many things that other persons may not get me to do. But thanks so much. I am really truly honored to be able to talk to you today about an area of emergency medicine that is particularly near and dear to my heart. Everybody knows I'm very much into point of care testing in general and ultrasound in particular. So today I hope to present the experience that we have had here in Jamaica in the context of the past, the present, and the future. So is everybody seeing my slides? Just checking.
Yes, we are.
All right. So how did this point of care ultrasound journey begin? The journey really started when I was a young resident in emergency medicine with an interest. And that interest came from my exposure to emergency medicine as I began to read about the use of bedside ultrasound. And this was something that was new to me, the use of ultrasound in the emergency room. Because of this experience and this interest, I paid attention to ultrasound, particularly in areas such as O&G, where I was able to see application of ultrasound in patient care directly in management of things like first trimester vaginal bleeding, which was particularly relevant to the emergency department experience. And I definitely began to read about this and learn more. So, driven by my recognition of the long turnaround times for radiology, coupled with my natural impatience, which anybody knows who knows me knows about, and a strong sense that learning ultrasound was actually achievable, I began to look for ways or think about ways that I could acquire this training. So while still a resident in the program, in 2001, I spent my money. I booked my vacation time and I went off to a 3-day ultrasound workshop in Texas at a place called the Advanced Health Education Center. And this image there is an actual image of the manual that I used on that course. I was taught by a woman called Janice Underwood, a nurse by profession who had gone into ultrasound training. And this was a really positive experience. I think it was a great way to start out my engagement because it was very much hands-on, very much supportive, and made you feel like you could do it. And indeed, I did. So I returned, I still have that manual, by the way. I returned from this workshop quite positive, quite engaged, ready to find, looking for ways to do more ultrasound. And so I approached the then head of department of radiology. This might not have been the best idea, as I was smartly told that if I wanted to do ultrasound, I needed to come and do radiology for 4 years, please and thanks very much. I retreated from that interaction, not daunted, but looking for other ways to engage with ultrasound. During that time, I graduated in 2001 and began to look for ways and became aware of the program at the School of Medical Radiation Technology. It took me a while to enroll because I was trying to figure out how to get this done, being a new consultant with a full-time job and needing my salary to actually pay my bills. In that time with Professor Phil Levy, he wasn't a professor at that time, brought a team from Wayne State University, himself and Dr. Teresa Terlecki, and they ran the first full ultrasound course at the hospital. And this was a good experience as well. But as a legacy item, and Dr. Edwards would refer to this as the big back machine, they left a used machine that we had in the department, and we began to mess around with ultrasound. Subsequently, I did enroll in the program at the School of Medical Radiation Technology at UWI, which was really run. So that's Dr. Levy, who is now Professor Levy. And subsequently, I enrolled in this program at the School of Medical Radiation Technology and commenced sonographer training and eventually received my certification. So I'm actually a formally certified sonographer. And I began right away to try to incorporate, even before I graduated, quite frankly, to try to use ultrasound in the department using the machine left by Professor Levy. Fast forward to 2014. In that time, what then happened was we really then set about teaching our residents in the program how to do some ultrasound. And very gingerly and very slowly, things became incorporated. And in 2014, for the first time, we used ultrasound images in the exams. And I remember that experience because we were very careful in how it was introduced. We were very careful. It was really a cross-campus discussion about how to be introduced. And we had to really make sure that all the campuses were able to give the residents a similar experience so that no one would be disadvantaged. I then had the opportunity to visit Wayne State University, and I met at that time a gentleman called David Amponsa, who's shown here. This gentleman really brought to my mind the idea of teaching medical students
ultrasound because he really built out quite an impressive program in undergraduate medical education there. Returning from that experience, and that experience was also made possible by Professor Levy, I was asked to do a presentation to the faculty board at UWI by Professor Tomlin Paul, now of blessed memory, who was really quite supportive of the idea of ultrasound training. The faculty received the presentation well, but voiced many concerns about how they would get this done, who would do it, where we'd get the machines. And so coming off of that presentation, it was kind of like, how are we going to do this? And it kind of stalled out. However, undaunted, I spoke with my colleague, Dr. Rhonda Hudson, who is in charge of our medical school, our medical student program in emergency medicine that we give to our fourth-year medical students. And Dr. Hudson was quite, as she usually is, supportive of the idea of training our medical students. And so I designed some teaching materials. We worked out the course, how the course would be delivered, and we promptly set about training or starting to expose our medical students in the fourth year to EFAS training. Certainly not the same as Dr. Amponsa's program, but it was a start. And very much we decided to go about it with a just do it approach. Around the same time, we incorporated the training week in emergency medicine for the graduate program. And up to that point, the ultrasound, it was really quite difficult because I was really the primary person trained. And so it would mean that throughout the year, I would try to deliver the training in modules stretched out over the year. And with the advent of training week, what then happened was that we gave a course. Incoming residents would get a full ultrasound course as they came into the program, and then this would give them the skills so that they could then practice the ultrasound skills as they went through the program. Unfortunately, as we all know, COVID-19 descended upon us in 2020. There was not, things held in terms of the training, but certainly we didn't do a lot of new things in that period. This is the image of a publication that documented our foray into medical student learning in ultrasound. And this, as I said, we then moved into COVID and things kind of stalled out. This slide here now shows, despite the COVID pandemic in 2021, I was approached to do a presentation at a conference that was put on by the Jaja Foundation, which is led by Dr. Trevor Dixon, who you see here. And Dr. Dixon is a diaspora Jamaican and emergency physician out of New York, who through the Jaja Foundation had been working with KPH and delivering ultrasound training over several years. I opted not to do the presentation myself, but to mentor a group of residents to do the presentation. This was a great experience for them because they recognized that they were just as good as their counterparts elsewhere. Subsequently, Dr. Dixon and the Jaja Foundation, with the support of the American Friends of Jamaica and the Butterfly group, brought about the Jamaica Handheld Ultrasound Project. And this was a very important project because it allowed persons to access devices. A big problem, even as the training was being done, was that people just didn't have devices. They'd go back to departments where they didn't have devices. And even at UWI, the machine that we had procured by then would go down frequently. And so this was mitigating against persons actually practicing what they were learning. Certainly as things progressed, we became course experts invited to teach on various ultrasound courses within and outside of emergency medicine, including courses in intensive care, and even a private course run by a radiologist called Ultrasound Comes Alive. So our skills were being recognized and things were advancing. This is a closer image of Dr. Dixon here, who, as I said, is the person behind the Jaja Foundation. And this is Mrs. Wendy Hart, who, through her partnership through the American Friends of Jamaica, was a really important support for disseminating devices throughout the island. We started with 6 hospitals, and the program has now spread to, I believe, almost 15 hospitals. So this was important. I want you to pay attention to this. This is after. This is when we received our first device. You can see, I'm not sure if you see my cursor, but you see the butterfly devices here. And here you see Dr. Hall Corey, remember that name, and some members of the team, our then manager and one of our phlebotomists, some members of the team. As we received our butterfly device, we were very proud, we were very happy. We had a system to track it, and we put things in place. At the time, the machine that we had, we did have a cart-based machine that did not work frequently and had really passed its useful life. So this provided a real lifeline for us. And we're very grateful that the Jaja Foundation saw us as an important partner. So where are we now? Presently, point of care ultrasound is embedded in our undergraduate program at Mona and in the graduate programs across all campuses. We have point of care ultrasound trained emergency medicine graduates at approximately 14 hospitals island-wide. And just to give context, we have approximately 23 hospitals in Jamaica that offer 24-hour emergency medicine care. So that's pretty decent, coming from a time where when I graduated, where they basically had graduates at 2 hospitals. We now have through JHUP, we now have devices at 19 hospitals. Quality assurance is largely provided by ultrasound champions at these hospitals. So this means that they have to get in contact with somebody, review the images, and that's something, a challenge for the future. We have done some research. We have done some research, mainly focused on the ability of local physicians to recognize various pathologies such as gallbladder pathologies, DVT, eye and renal pathology, but most have not been published. We do have a few publications. There was one early publication that looked at first trimester bleeding, showing significant reduction in waiting times and showing that our rates of definite EP were comparable to international figures. And we have also have a publication outlining the genesis of the JHUP program and detailing how the program works. But this is something that we can stand to improve. Ultrasound is used across a wide range of clinical applications. And I think most persons here will be familiar with most of these. Several protocols have evolved, lots of alphabet protocols, Rush and Blue and CASA, and they can sometimes be quite complex and be confusing. The important thing to recognize is that point of care ultrasound should ultimately bring value to the patient, and it does so typically by reducing time to definitive care, reducing ED length of stay. It may increase access in some cases to definitive care, meaning, for example, a patient who may have had some shortness of breath in the context of a DVT is presumed to have a PE, and so treatment can begin more quickly, and persons can be more confident of the treatment given, or rapid identification of bleeding in persons who have trauma or other conditions, right? So one good example is the actions of a team. And if you notice here, you see Dr. Hall Corey again. And this team was recently highlighted in the media, right? And our Dr. Hall Corey, and she's still my doctor, although she's moved on. The team here, I'm just going to play a quick video for you that
moments when the patient arrived with the stab wound to the heart and how the team prepared for that emergency surgery.
Oh, yeah. What's going through my mind? Okay, we need to keep this patient alive. You know, the patient arrived. The team immediately recognized that this was a life-threatening chest injury. Mm-hmm. And so our focus was really rapid assessment, okay? We considered what organs could be affected. Is it the heart? Is it the lungs? Is it both? Is it in the abdomen? Mm-hmm. What other injuries are we dealing with? And while we're making that assessment, we're also making all the efforts to stabilize the patient. The major turning point really was the use of bedside ultrasound, which quickly diagnosed that the patient had blood collecting around the heart, mm-hmm. which was preventing it from pumping.
So this is an important case that was very recently in the media quite a bit, brought a lot of positive attention to Maypen Hospital. And this patient survived a cardiac tamponade with no massive transfusion protocol. The patient went home, I think, approximately a week or so after the procedure and is perfectly fine. And it speaks to the power and the impact that point of care ultrasound can have by causing rapid advancement of care. So point of care ultrasound is making an impact. It impacts our patients, but also our students and our faculty. This message was recently shared, very, very recently, and I share it here, by one of our residents, Dr. Chadine Lewis Myers, who had recently practiced procedure and was congratulating Dr. Eric Williams, one of our faculty, on being able to make a positive diagnosis of cardiac tamponade. And here you can see the video that she shared, showing a patient at the Spanish Town Hospital that she was involved in the care of. And you can clearly see, and I hope you can see my pointer, you can clearly see a very small RV and that hyperdynamic activity of the heart, which is typical of a cardiac tamponade. So very impactful modality. Here at the University of the Hospital of the West Indies, which is shown here to the left, unfortunately, we continue to operate, and I have to mention this because, you know, it's a pet peeve, the severe overcrowding that continues to persist, and we have to try to advance and do ultrasound cases in an environment which is often quite difficult. Nonetheless, we persist. These are some cases from the UHWI hospital, and this is actually one that was done fairly early in my ultrasound journey with one of my residents, in a patient who presented with chest and abdominal pain and normal forelimb blood pressures, but we were very suspicious of an aortic dissection, and we looked using the ultrasound. And here you can see on the transverse view an intimal flap within the aorta, and on the longitudinal view, a nice intimal flap. Very good, very good. But this, while we worked to titrate his blood pressure, what was really nice about this case was that we were actually able to identify the origin of the flap in the aortic root. This is actually the aortic root, which was quite wide in this patient as a result of the dissection. And this little thing here is the intimate, is where we thought the flap originated. And this actually correlated pretty much. It went from the aortic root to the bifurcation. We were able to track it all the way down, and it correlated exactly with the CT angiogram that was done, which gave us a little bit of pride. Now, every emergency room doctor knows what this is. Usually we administer pain meds, we get an x-ray to rule out an associated fracture, particularly if a mechanism is traumatic. Then we administer sedation, we reduce it, we wait for the patient to wake up, and then we get check x-rays. This is lengthy and it is time consuming. On this particular night, it was an evening when we worked, I looked at Dr. Oral Rose, no longer in emergency medicine, currently in orthopedics, and I thought, why not use ultrasound? So this is the image of the ultrasound that was done. And here you can clearly see here the glenohumeral fossa and the humeral head, which is quite properly outside and displaced outside of the humeral head, indicating that the patient has a dislocation. We then said, having diagnosed it with ultrasound, right, we administered intra-articular lidocaine under ultrasound guidance to facilitate the reduction. Okay, so here you can see, and this is the needle right here, you can see the injection of the lidocaine as it enters the joint. Subsequently, we were able to show, and in the corner here, you see the image of the dislocation. And now you can see the glenohumeral fossa with the humeral head relocated back into the fossa. This patient did not have pre-reduction x-rays because he actually had an atraumatic mechanism. So we were able to do post-reduction check x-rays to confirm, and this is really largely for orthopedic surgeons. We were quite convinced it was in, and discharged the patient who was not sedated and therefore did not have to wait to be recovered to go home. So we really were able to significantly reduce his length of stay. This particular patient was seen quite recently, approximately a week ago. He presented with 5 days of intermittent chest pain, and significantly, he told us that his father died of a myocardial infarction when he was a child in prep school. The patient had a 5-day history of intermittent chest pain, so certainly lytics was out of the question. A STEMI call-out was done, but no PCI was immediately available. So we opted to, this was his ECG, and you can see clearly that he has ECG changes quite significant in the anterior and anterior septal leads with deep Q waves and ST segment elevations, really quite florid, nothing anybody should hem and haw about. However, surprisingly, we did have a little bit of a challenge when we made the STEMI call out. So just looking at this now, this is the parasternal long axis view. This is the right ventricle, this is the left atrium and left ventricle, aortic outflow tract, and this is here the descending aorta, take my word for it, and this is the pericardium. And here you can see some black fluid here, a small pericardial effusion, but there's overall a good squeeze, and you can see the anterior leaflet of the mitral valve, which goes all the way up to the septum, indicating decent squeeze. He was not in failure, but that was fine. We then looked at the parasternal short axis, and if you look at this part of the great thing about the parasternal short is you're able to assess the wall motion abnormalities, and this area of the heart is not moving as well, say for example as here. So we thought he had some wall motion and abnormalities, and we did a apical view, and the septum here just really wasn't coming in and squeezing well, in keeping with the findings on the ECG. Unfortunately, PCI was not available, and when I checked in on him the following day, attempts were being made to get financial clearance for his cath and potential PCI. My last case was this weekend. Where an obese female fell from a height, and by a height I mean the top of her rooftop. I don't know if this happens in other parts of the Caribbean, but this lady hangs out her washing on her roof. There is no railing, and so unfortunately, we're not sure why, because she wasn't able to tell us, but she fell. And when she presented, she was confused with a GCS of 13 to 14, a low blood pressure despite a normal pulse rate. And while she said she was not in pain, she was clearly having tenderness over the right side of her chest. We opted to do an EFAST examination, and this is the cardiac view. And, she's not in failure. This is good. There's definitely no free fluid. We moved on to do a right upper quadrant view. Now, you can see the challenges of doing ultrasound in real time. We had a rib shadow here. We could see the diaphragm. I was thinking there looks like there might be a little fluid here. We were kind of saying, well, it looks like we're seeing a spinous process above. So we were concerned that there was fluid in the chest on the right. We were able to see the Morrison's pouch quite clearly, so there was no evidence of intra-abdominal fluid on the right. Unfortunately, the images of the left upper quadrant were not saved, but they were normal and did not show any fluid in the chest or the abdomen. This is all image of the pelvis. Here, you can see the catheter bulb here, showing the deepest part of the pelvis. The cervix is here, and this is the fundus of the uterus. And there was no free fluid appreciated on that image, or on the transverse image of the uterus here with the pouch of Douglas back here. So that was fine. Her lung images are shown where we have clear movement at the pleural line with comet tail artifacts, and we can see that we see a nice seashore indicating that there is no pneumothorax. We went back and repeated her right upper quadrant view at the end of the EFAST, and here now we're clearly seeing the diaphragm, and there's fluid here. If you look right here, you can actually see a little bit of lung coming in, and you can see the spine sign extending above the diaphragm. So we were quite convinced that this lady at minimum had a hemothorax. The patient actually had stabilized, her blood pressure improved with a fluid bolus, and she had CT done which confirmed the hemothorax. A chest tube was sited which drained approximately 500 cc's, which did not change significantly with monitoring. She was subsequently admitted to general surgery. She really was pan scanned. Her brain was normal, and her mentation improved subsequently. She does have an undisplaced C7 fracture with some rib fractures, not surprisingly, and a pelvic fracture, and she's awaiting management for that, but she's doing much better. I actually saw her daughter last night who gave me an update. So what are the challenges? Well, device access is improving, but the Ministry of Health really needs to step up and actively support by providing machines to hospital EDs, many of which share devices with the other departments, commonly O&G. We do have the butterfly devices, but these can go down, and we don't have local support for them. So when they go down, they have to be sent overseas, and that breaks service. However, the doctors who are in charge of them are proving to be good stewards, and that's a good thing. Emergency physicians are not the only ones doing ultrasounds. We have teams like ICU and let's not forget the cardiologists, O&G, and of course, GPs in private practice are acquiring devices, and this always raises concerns about training and certification, radiologists remain very concerned about what they see as the training of non-specialists, by which they mean non-radiologists, and there is a distinction. But the fact of the matter is that ultrasound access is there and it's running ahead of training. And so what we should be looking to do is to catch up and provide persons with training rather than limit their access to the modality. We would recognize that we don't presently store images, and this is something that as emergency physicians, just be clear, we should be doing that, and we should be placing our images in notes, as it is good practice, it's good for research, it's good also for any medical legal issues that occur, although the incidence of medical legal issues using ultrasound is quite low. In actual fact, when I reviewed this topic the last time, the only medical legal issues I found was 2 cases where persons were sued for not using point-of-care ultrasound. We need to look at research. We are doing some research, but it's not translating into publications. And to be honest, I think we have been held back a little bit by the consistency of machines being available. Because once the machines go down, if you're doing a project on ultrasound, then your project gets messed up. And we also don't have a repository to store the images for retrospective studies. So that's something we need to probably look at. At UMONA, we're moving to assess some of the gaps in training by creating opportunities for physicians who have an interest while working. We know we need to accommodate physicians. They can't just leave their job and come and do things. So we're looking at this. I can't say very much more now, but you'll be hearing much more very soon. So what of the future? We must be concerned about quality assurance for training with a focus on clinical integration. A lot of the training focuses on image acquisition in a lab, but not so much in the real world setting, and there needs to be more focus on integrating the findings, positive or negative, into patient management. Paramedical services in many places are already using ultrasound, and it's going to happen. Our nurses and EMTs will someday use these modalities alongside doctors, and I believe that we will also see more rapid uptake across subspecialties which are not using point-of-care ultrasound as much as we do. We're in Jamaica. I don't know about other countries. We're not offering EFAST at our ATLS courses, and I would again use this forum to offer to do that, as I think that is something that we should be doing. We spoke about storage of images, and again, I really do want to see us progress to the point where we're doing outcome-based studies in point-of-care ultrasound that are worthy of publication. Can't talk about ultrasound and not speak about AI. All right, AI is going to impact and is already impacting the use of ultrasound. It is being incorporated into devices like the Butterfly and other ultrasound platforms to enhance image optimization. And there will come a point where your image quality will be adjusted by AI for you. There will come a point where AI will give you guidance as to your image interpretation and your image acquisition as you do the studies. And so learners will be able to monitor their own use and track their own competence through the incorporation of AI into these devices. And that's already started, really. We do see things like the development of probes that can be placed and used in an isolation setting on the patient, while allowing persons outside the room who have the ultrasound competent to access images acquired by the device to make clinical decisions. That was something that was trialed during COVID. I don't see it on the market just yet, but these things are in train and the technology is improving rapidly. Quality assurance is an area that AI will impact by allowing the evaluation of images, not so much by a human person. So right now, if my resident does a scan, I have to go and review the images with them, but AI is going to review those images for you and render a report on the adequacy of your images. And again, this is going to help to allow more rapid uptake by learners of the modality. And of course, teleultrasound is something that will allow the expansion of point-of-care ultrasound into underserved areas. So point of care ultrasound is here to stay. It is doing well. We are expanding. There's still a lot of work to be done, and I suspect I should take a little bit of the responsibility for not for some of the things that have not been done. But we continue to improve, and I look forward to any questions that might have arisen from this presentation at the appropriate time. Thank you so very much.
Thank you very much, Dr. French, for such an engaging talk. I must say it's not lost on me that our stethoscope, which is our symbol of, being healthcare workers, has been replaced by a probe. I did see that. It was not lost on me,
Yeah,
so
you
soon.
enjoyed the AI generated images.
We did, right? So soon we won't be walking around with our stethoscopes. We'll be walking around with our ultrasound probes. Boy, the path to the future is actually very interesting. All right. So our penultimate talk is from Dr. Nordia Thompson-Newell. Now, it is very interesting to introduce Dr. Thompson-Newell because she is a consultant emergency physician here at the University Hospital of the West Indies. She completed fellowship training in pediatric emergency medicine as well as simulation at the Hospital for Sick Children and the University of Toronto, Canada. She holds a certificate in Teaching Scholars Program at Sick Kids, focused on evidence-based teaching and learning strategies. With over 12 years, even though she looks like she's, 2, but she has over 12 years of clinical experience across hospitals in Jamaica and Canada. She's committed to advancing medical education and patient care. She has taught both undergrad and postgraduate medical trainees. Over the past 4 years, she has led interpersonal simulation-based education, both virtual and in person. In fact, we actually had some of that during our retreat, mandatory retreat for the medical students by Dr. Rhonda Hudson. She currently serves as a member of the board of directors of the International Pediatric Simulation Society. She co-chairs the IPSS Academy and the IPSS Sirius Channel Administrator. She has held leadership roles with the Jamaica Emergency Medicine Association, including vice president and assistant treasurer. Driven by a passion for improving clinical care and patient experience, Dr. Thompson-Newell continues to champion the use of simulation to elevate standards in both adult and pediatric emergency medicine across Jamaica, the wider Caribbean, and areas across the world. Help me in welcoming Dr. Nordia Thompson-Newell as she speaks to us about a relatively new area as a subspecialty in emergency medicine, simulation in medical education. Thank you very much. And over to you, Dr. Thompson-Newell. Thank you for offering to present to us.
Of course. Well, good afternoon, everyone. It's truly an honor to be here to celebrate the Emergency Medicine Day today. And I will speak on simulation in medical education. I have a small technical challenge. Let me pause for a second. Apologies for that. Thank you so much for your patience. It's truly an honor to be here to celebrate the Emergency Medicine Day. And I'll speak about a passion of mine, simulation in medical education. I did complete my fellowship at the Hospital for Sick Children and the University of Toronto some time back, and I'm really happy to be home. So today we will sort of define what clinical simulation is. We'll look briefly at the historical context of it all, explore some benefits of simulation in medical education, look at the simulation modalities that we use, discuss the educational model, which is key for simulation in medical education to be effective. And of course, there are always limitations with everything, so I'll look at some of those. I have no financial or relationships or conflicts of interest to disclose at this time. So clinical simulation is the Dr. Gabo, David Gabo, was an anesthesiologist at Stanford University, who is also called the godfather of simulation, described clinical simulation as a technique and not a technology. And a lot of the times when we speak about simulation, we speak heavily on the technology and the high fidelity need for realism, but that's really not it. The technique is what is important for us to have effective simulation. And it strives to replace or amplify real life experiences with guided experiences that replicate substantial aspects of the real world in a fully interactive manner. So in terms of the historical context, simulation originates in aviation. So in the early 1900s in World War II, they had the Link trainer that was used to train thousands of pilots. And we'll agree that, you know, the safety of aviation and pilots is critical because they have significant number of persons' lives essentially on their hands. And there is no room for human error. And simulation is key and has been key in bridging that gap in reducing human error. And they introduced the crew resource management to sort of systemically minimize human error in aviation. The early 1900s in nursing, they introduced like the first full body size simulator. It was a wooden simulator called Miss Chase that pioneered hands-on nursing skills training. As we project to the mid-century to present, there was sort of a simulator boom where there was introduction of simulators such as Resusci Annie, Sim1, Noel, SimMan, all these terms you may or may not have heard in terms of simulators or classic simulators that we all strive to get. Important as well, stemming from the crew resource management from aviation, our godfather, David Gabo, was the first to sort of translate that into medicine, where he described crisis resource management in healthcare. And this focuses on non-technical skills, including communication, teamwork, situational awareness, and team leadership. And simulation plays a significant role in us mastering or improving our skills in these non-technical area, but it all stems from the aviation industry. I think this is important for us to know, look at sort of the paradigm shift in training. Probably most of us would have heard of the apprenticeship model, which speaks to the see one, do one, teach one in medicine. So we see one in the clinical space, then we do one, and then we teach one. This has its limitation, particularly the variability in the clinical experience. There's no guarantee that I will see a cardiac tamponade case in my rotation in emergency medicine. But also, if I saw one and the next step is to do one, am I fully competent? Am I comfortable with doing this procedure, having only seen one? So the potential risk to patient safety is quite high in this model, though it's the traditional approach that we utilize. Simulation has helped to, or should I say, with the expansion of medical education and healthcare becoming more and more complex, there's a need for a standardized, reproducible training method. And simulation helps to fill that gap where we now say, see one, practice many, and then do one. Where in this case, or within the simulation model, the patient's safety is assured. In fact, the patient's risk is removed in the simulation model. And if we're able to see one in the clinical space, practice many, then when it's time for us to do one, then we'll be way far more comfortable and competent and capable, and significantly reduced risk of human error in these instances. Just to look at sort of the evolution of simulation in medical education, this graph shows the simulation research over time, and it shows a trend, sort of the annual publications related to simulation-based medical education with a steady increase over time. We note the highest published within the last few decades was in 2022, and that's coming from just over 100 publications in 2004. So we've seen, based on this, that there has been significant growth over time with the increased use of simulation in medical education. The sort of the benefits of simulation include things such as safety, the skill, the adaptability, and we also speak about the realism and feedback that we are able to provide. So in terms of safety, we can all agree there's no harm to patient because there's no patient, there's no real patient present. A safe learning environment is provided for the learners. So the benefit of that is that we reduce the cognitive load on the learner. So they're more likely to engage and benefit from the experience and being more capable and competent once we go into the clinical space. We'll look at simulation in terms of the adaptability of it all. We're able to change a scenario based on the level of the learner. So we can have the same scenario, but make it as simple or as advanced based on the learner that we are engaging for the simulation. So we're likely to make it simpler for medical students and more advanced for like senior residents or for faculty members who are going through simulation-based medical education. There's also the opportunity for practicing of infrequent presentation, right? Because we may not see something being in a department for 1 year, but it's sort of a high acuity, a thing that if we make any error, it can be significantly detrimental to the patient. And so simulation provides the opportunity for us to be exposed to those clinical scenarios, clinical presentations, so that when those rare cases come in, we're able to better manage them. In terms of skill acquisition, there is enhanced skill acquisition, of course, a reduction in error, as well as deliberate practice where learners perform tasks repeatedly without risks to patients. And I'll keep saying that there's no risk to patient. That's a big benefit of simulation. And also repetition is important to develop proficiency and improve skill retention. It also provides realism and an opportunity for feedback. Participants are able to get hands-on practice with real medical equipment. So everything can replicate the clinical space, and you put a mannequin to replace the patient, right? So we get that hands-on practice that is needed, and we are able to create realistic scenario that replicate those that would see in the clinical environment. And it consistently provide valuable feedback tied to the decision making. So the facilitator observes during the scenario, and you're able to debrief and have a discussion about exactly what transpired. How can we, things that were done well for reinforcement and things for improvement. In terms of just the strategic application of simulation, we speak about the zone of simulation matrix, where the model really is based on the clinical scenario characteristics, including the acuity or the severity, as well as how often we see these cases. And simulation is in this zone up here, where particularly it's excellent for high acuity, low frequency or low opportunity events, as well as some low acuity, low opportunity, and some high acuity, high opportunity that we must master the skill. And the zone of simulation depicts where healthcare simulation may be most advantageous over other methods of delivery in medical education. So it's not the only place, but it depicts where it's most advantageous to utilize simulation. So we'll just shift a little bit into some of the simulation modality that we use. And a lot of the times we hear about high fidelity sim, but once you use the right technique, low fidelity sims can be just as effective. When we speak about when we speak about the environment itself, we can speak about the physical or tactile versus the virtual environment. And you may have a low fidelity physical modality, such as task trainers that you may use to teach a skill, such as IV access placement. Just an arm for IV access placement. That's a low fidelity physical modality. Or just a low fidelity mannequin, for example, the torsos that we may use to teach cardiopulmonary resuscitation. We also have low fidelity virtual simulation, which are screen-based virtual simulation. I'll show you a video of an example shortly, such as you may use Google Slides to create a sim, and you're able to use the simulation technique to deliver that teaching opportunity. There's also high fidelity physical sims, where we speak about the high fidelity mannequin that breathe on their own or breathe with a prompt. They have breath sounds, they have heart sounds. When you examine, you may hear crackles or wheezing or whatever you want based on the scenario that you're creating. You can have the mannequin provide those signs to the learners so that when they assess the patient, they would find those things. They may have a cry, a weak cry, for example, you may be able to get the mannequin to show an enlarged tongue and angioedema, enlarged lips. Those types of simulators are more high fidelity simulators. Standardized patients as well, where you can place or train an individual to portray real patients accurately. And this is particularly useful for learners to practice things such as history taking or physical examination and communication skills, such as breaking bad news in of course, a patient-centered context, right? And then in the center here, when we speak of hybrid simulation, it's just a combination of more than one modality. So you may combine, for example, you may combine a standardized patient and a low fidelity physical simulator, such as a CPR mannequin, right? And that's what we call hybrid simulation. So next we'll show you here some of the physical modalities. I used examples from some of the sims that I've been a part of. So to the left on the screen, we have task trainers. This was a setup that was in a conference room for a one-day workshop that we did on pediatric emergencies. And essentially we provided multiple airway task trainers and airway adjuncts that the participants were able to perform different or practice different airway interventions. To the right, there's an example of a high fidelity mannequin on a warmer. So this space could replicate what you would see in a NICU setting or in the emergency department. And in the simulation sensor, they put equipment that mirrors what is in the hospital setting. So this is a similar warmer that like what we would see in the NICU, so that we can run a neonatal resuscitation that replicates the NICU. Behind here, you see the headboard with like oxygen and suction and medical air, as well as like a code blue button is there, as well as a monitor is projecting so that vital signs can be projected as the case progresses. And this mannequin would cry and, you know, breathe spontaneously. And once you turn it on and have breath sounds, heart sounds, have a pulse and all of that. I'm not sure why my video is not showing here. Let me see why. You're not seeing a video, are you, Dr. Edwards?
No, we're not seeing it now. No.
Just a moment, sorry. Where is Loy?
You want her to come and help? Yeah.
We could ask somebody from our technical team to assist.
All right, so here we have sort of a video of a simulator, a high fidelity simulator set up in the Sim Center. You can see the backboard, there's a monitor, the simulation facilitator, we're able to change the rhythm as things go along, right? And it is the participants, it's important that they check intermittently to see if any changes, just like in the clinical space, if we don't reassess the patients and check the monitor intermittently, we won't see a change. So usually we have different stages, and once we are, we progress the case as things go along. So changes will reflect on the monitor as they would in the clinical space. All right. In terms of other modalities, so the VR or the virtual reality simulations, essentially VR headsets are used, and it sort of give an immersive the participants immerse into the clinical environment. It feels real, like everything else blocks out, and the participants are able to perform procedures, intervene. You can use the VR headsets to listen to the patient's chest, for example, as well as to pick up a blood pressure machine and attach it to the patient. These types of things can be done with the VR headsets, and persons can be engaged. But certainly it's, learners are able to do on-demand, sort of indefinitely repeatable clinical scenarios over time. And this is, significantly beneficial. And it allows for the immersive visual and auditory stress inoculation, which is a specialized technique that trains individuals to remain calm, focused despite chaotic, loud, or overwhelming situations or overwhelming noises. Just like in the clinical space or in the NICU, you have monitors constantly going off. So we're able to simulate that with the VR headset. You hear all the sounds and all the tones in the clinical environment, and learners are able to immerse. And this has been picked up and widely used for various things, including like practicing surgical techniques, for example. I've seen it used in terms of anesthesia and airway management and interventions as well. When we spoke about the low fidelity virtual sim, I'll share a brief video with you on the virtual resuscitation room, which was created as a response to the COVID-19 pandemic and has been widely adopted. I've been a part of a group, and we have utilized it in training, particularly in pediatric emergency medicine, in groups in countries such as Pakistan and Bangladesh, that we engage emergency medicine residents who see lots of children with no formal training. So I'll do a short video for you to see what that looks like.
Learners click and drag the monitors into place over the patient, while facilitators type in the vital signs on the monitor on the right. Examine the patient.
So slide 1, they'll be there. That's a patient that they have. Once they, attach the monitors, we're able to change it on screen, put in the heart rate, put in the oxygen saturation, put in the blood pressure. Once the learners have attached or moved the different monitors over, once they've said they've connected oxygen at X liters per minute, then we put it in as they are verbalizing the actions that they're performing. They have a space for note takers, and whoever given orders, the note taker is able to document the orders as well. Then if, for example, they're at airway assessment, then you're able to say, please go to slide 4 and assess the airway as you see there. And you're able to add sounds as well, with a stridor, wheezing, whatever it is that would be important in terms of depicting the case to the participants and learners. Those would be placed within the slide for them to interact with.
Around his mouth and a rash on his cheeks. This is what I hear.
Apply oxygen to the patient. Grab extra airway equipment you might need from slide 3, copy, and then paste into place on slide 1 at the head of the bed. Grab medications from the med tray, copy, and paste into place. You can defibrillate your patient. Describe your findings on ultrasound. Work through the steps of a procedure.
I don't know. Okay, yes, wonderful. So let's do that. All right. So that was the low fidelity sim of the virtual resuscitation
Learners,
poem
click and drag the
that we just played. I think we can't speak about simulation in medical education without touching on this component, the in situ simulation, where this occurs within the clinical environment rather than an external space or training facility. And this promotes learning and improve clinical care. So the environment can be in the ED, in cubicle 1, in our hospital, or in your resuscitation cubicle, or it can be in the ICU, in a cubicle in the ICU, or on the ward on a bed, or in the NICU, wherever you are, wherever you normally see patients. And this is important in terms of, you know, improving non-technical skills, right? The crisis resource management skills in medicine, including communication, situational awareness, team leadership and teamwork, right? Or leadership and teamwork, those things are important. And it also helps a team to benefit from locating items in their natural space. So where do I normally keep my my kit for my chest tube set, for example? I need to run and grab that. Where's my airway trolley? Where do I normally find a bougie, a gum elastic bougie? All of these things you're able to simulate so that you're able to pick up and find the things that you need within the space. It also, you know, allows for team-based and interdisciplinary team training. So you can create in situ simulation, for example, with infrequent cases such as neonatal resuscitation. We collaborate with the NICU team, and we simulate maybe a mother who comes in and delivers a baby in the emergency department. We simulate from the arrival of the mother to cubicle 1, delivery. So we would collaborate with the gynae team, and we would collaborate with the pediatricians and the neonatologists for them to come down. We have a process, and that allows us to see how well we're able to collaborate. Are there things that are working currently and working well? Are there things that are not working so well that we need to improve? So it allows for sort of a systems testing as well, and process testing in terms of how our current workflow is and things that we can identify to improve, but also helps the team to work in a collaborative manner and allows for interdisciplinary team training. So another important component that I can't speak about simulation and not touch on is the three-phase sort of educational model, or the methodological loop of simulation. And it's phase to pre-brief, scenario, and debrief, where pre-brief is sort of the initial session or the events that happen prior to the simulation. And it includes providing participants the objectives, introduction to the environment that will be utilized, the space that will be utilized, as well as it may involve the work that you put in prior to the day of the simulation. It may involve providing preparatory material to your learners, because in simulation, we always set the learner up for success. And so you want to ensure that the material that is needed is provided for our learners. And we also describe things such as establishing a fiction contract, which is, we know this is not the real life scenario, right? We don't have a patient. However, we encourage the participants and facilitators, everybody, to suspend disbelief and immerse yourself within the simulation as if it is the real clinical environment. And those things are important to establish in the pre-brief. And one critical component of the pre-brief and important for simulation-based medical education is establishing psychological safety. Now, I know it's context specific, it's not second nature in some setting, but in simulation, it's very important that learners feel safe, right? It's a space where mistakes are allowed, and we say that. But guess what? In sim, we learn from them so that when we go to the clinical space, these errors or these mistakes that we don't make them in the clinical space. And these things will, once we establish that and maintains it as facilitators, we're able to decrease the cognitive load and the stress of the learner, so they're more likely to benefit from it. The scenario is sort of the guided interactive experience or the simulation component of it all, where the learners engage in a scenario. They may perform a procedure, manage a case, and that tends to last roughly 10 to 15 minutes, depending on what exactly is happening. The debrief session is critical, and there is no sim if there wasn't any debriefing. None, okay? Because this is where our learning occurs. It's a session that happens after the scenario, and it allows learners or participants to receive feedback on their performances in a safe way, also reflect on actions during the sim, and for us to discuss ways to improve. So I like to utilize the technique in which I speak. We discuss both things that went well and areas for improvement in a way that everything is clear to the learners and the facilitator. And it's not a unidirectional thing. It's a lot of the times you engage the learners and they are able to, explore things that happened in the scenario. And of course, if there are key or critical errors that were made, there are techniques that we're able to explore with the participants to ensure that that comes up. And this is really where a lot of the learning takes place. And the debrief as well, it's the longest component of the simulation. So if the pre-brief and the scenario lasts for 20 minutes, then the debrief is roughly 30 to 40 minutes, right? Our formula is 1.5 to 2 times how long the scenario and pre-brief lasts. That's how long debrief lasts. It allows for just reflection and any closure of any gaps or key learnings based on the objectives that were set out for the simulation. Of course, there are limitations for simulation in medical education. One of the biggest factors is costs, because the initial capital expenditure for particularly high fidelity sim, which it seems most people, that's what we want, right? We like the high fidelity stuff, and ongoing maintenance. Those things are very expensive. So it tends to be a limiting factor. Things such as technical expertise, especially in the realm of virtual reality or advanced digital simulation, these require specialized IT and operational support, which finding the expertise is one thing, but also the cost of it is another thing. Faculty availability is also a challenge. Finding trained clinical personnel with protected time to facilitate high quality simulation is also a limitation. And human variability, particularly when we look at standardized patients, there may be variability in the standardized patients' performances across different sessions. So training is also important, and there is a cost to it. So in closing, simulation, in simulation, the modality is only as effective as the methodology. Whether we're using a basic low fidelity mannequin or a fully immersive VR environment, clinical simulations succeed because it is a structured and guided technique, not just a technology, as our godfather, Dr. David Gaba, has said. Thank you all so much. I look forward to any questions. These are my references.
Wow, thank you very much for that, Dr. Thompson-Newell. Are you trying to say that we can soon be pilots because we're utilizing their technology? I'm ready. All right, really engaging talk. Seems a lot that we use there. We don't have any excuses to get high fidelity mannequins if it is that we can get the programs that you suggest. And of course, you'd have to be taught how to use it, so we can engage our learners. Because I'm not into sometimes, see one, do one, teach one, because as you said, patient safety must come first. So thank you again, Doc, for that interesting presentation on simulation medicine. We're left with our last talk, and our last talk is from Dr. Rhonda Hudson. She is a native in Georgetown, Guyana. By the way, she has that flag flown very high on her door. She received the Bachelor's of Medicine, Bachelor of Surgery degree from the University of the West Indies, and later her Master of Science in 2001, as well as her DM in Emergency Medicine in 2002, also from the University of the West Indies, Mona. In 2009, she received her coveted Master of Science in Sports Medicine. She is currently employed as consultant emergency physician at the University Hospital of the West Indies and head of the emergency medicine division, hence my real boss. She's also a lecturer at the University of the West Indies, Mona, in the Department of lecturer in emergency medicine in the Department of Surgery. She's the coordinator of the emergency medicine clerkship for medical students, as well as the stage 2 coordinator for years 4 and 5 medical students of the MBBS program at Mona. She is very traveled, right? She was a team physician to the Jamaican athletes for local and international games in Puerto Rico in 2010, Pan Am Games 2011, Toronto 2015, Lima, Peru in 2019, Commonwealth Games in Glasgow 2014. So when she's not traveling to go and watch, she's traveling to go and work. Since December 2021, she has led the executive of the Jamaican Association of Sports Medicine in the inauguration of innovative programs, as well as continuation of service to sports community of Jamaica. She's their immediate past president. Professionally, her areas of interest consist of the management of sexual assault cases, ECGs, and toxicology. She was also my DM advisor. I tell you how proud I am to speak of Dr. Hudson as she guides me in my professional life, and to introduce her to give us a talk on on-field injuries and athlete triage in sports medicine. Over to you, Dr. Hudson.
Thank you very much, Dr. Edwards. And just to let everyone know, Dr. Edwards hounded me until I agreed to talk on something in sports medicine. She wasn't satisfied with just asking me to do opening remarks. I told her the only way I would do it is if I had to do something that I had already done. So I presented this at the team physician course in Barbados earlier this year. So we'll just go ahead with that. All right. I solemnly declare that I have nothing to declare. Now, to ask a group of emergency physicians what is triage might sound a little bit insulting, but you might see where I'm getting with this kind of approach. What we do know, it's a rapid assessment to make a rapid decision. And in a hospital setting, an emergency room, the idea is that we sort patients into categories that determine who gets seen first. All right. And there are several triage systems that have been developed. We use the emergency severity index system. But again, regardless of which system you use, the aim really is to decide when you have a lot of persons who get seen first, and it helps to predict your disposition of the patient. So persons who are deemed at high risk likely will need admission and so on. So for our system here at University Hospital, we use the ESI system here, levels 1 to 5. And again, we look at various parameters and we determine, well, if you're a level 5, well, you can wait a little bit and so on. Now, when it comes to sport triage at the individual, it's at the individual level, and it says on field. So we're going to talk about what happens on field. It's a slightly different aim. So with an individual, it's not whether or not the patient is going to be seen first or second, barring a mass casualty, of course. The question is what level of care is required and how soon am I going to get or make a recommendation for the athlete to receive such care. So similarly to what we would do in a hospital triage system, on-field triage rapidly identifies athletes at risk of a catastrophic outcome and the need to refer immediately for care, decide what can be quickly treated on the field versus what cannot. It of course helps to limit morbidity and mortality, and it ensures rapid recovery and safe return to play. Now, event preparation is very, very important, and really it should be done before you need to triage the patient. And that's important. And as emergency physicians, we understand the need to prepare for eventualities. How might we do this? Well, one of the things you have to know the event. So you need to know the demands of the particular sport. If you are going to be talking about on-field triage of injuries that may occur in a boxing ring, that is far different from what might happen if you're managing a game or covering a game of field hockey with those awful sticks that they use to bang each other with, apart from banging the puck, right? So it allows you then to assess the likely injury risk and the type, and to predict what types of injuries you might have, and therefore know what it is you need to do. You need to have an idea of the number of athletes and their ages. All right. So if you're dealing with youngsters, it's going to be very different. And if you're dealing with maybe you're doing you're covering a recreational game where the majority of persons are over the age of 65, for example. But also you need to know the rules governing on-field medical intervention. As emergency physicians, we are accustomed to when we see something, we rush into and we try to assist. But that is not always the case. We will not be allowed necessarily to do that. So you need to understand the rules of the game that determine how you are going to interact with that injured athlete. You need to consider the venue, not just its physical structure, but yes, how close is it to a major hospital, or what is the next available hospital that is going to offer care above that which I can give to my athlete at that time. And that needs to be factored in to any sort of preparation that you will need to have. And with that, look at geographical hindrances and the traffic, right? Those of us know that our national stadium in Kingston, it's in an area that after 5 p.m. and between maybe say 4:30 and 5 p.m., you're going to have a lot of trouble if you have a patient who requires emergency care to travel to our hospital. is going to be a very, very difficult task. And therefore, how would you plan to get to a hospital or facility when you have these hindrances? And then you look at the environment. Is it cold? Is it hot? What other things do I need to consider apart from the actual game injury itself? And then this is something that you need to consider depending on the type of sport and the level of spectator involvement and rivalry. So apart from the injuries that the athlete might sustain while playing the sport, do you then have to consider the possibility you may have a spectator riot because you have two rival factions that are highly charged playing, and may that impact your athlete as well as you may now have a mass casualty on your hands. Once you've done that, you then have to plan your medical teams. You need to know the team. What category of staff do you require? Are you okay to just have a physiotherapist on board? Do you need everyone? Do you need a physician? And what level of physician do you need? You have to consider whether either it's a requirement by the sporting organization that these persons are trained in or certified in courses like ACLS or ATLS, the level of experience of the personnel, because you may very well have someone who has a degree, who is certified, but may not be experienced in dealing with cases on field. And therefore, that may very well impact the care that that athlete will have. Not just ambulance personnel, but do you have an ambulance? Now, one of the things that I do, and we make a recommendation from our association, is that we do not cover any sporting activity if there is no ambulance. And by ambulance, I don't mean a transport facility or transport agent. I mean a fully equipped ambulance on board. There must be at the very least one. So we make sure that that is available because we may very well need it. And then you look at your external medical support, your medical station. So apart from what's happening on the field, your medical station locally, for example, what do you have at the main area, and then your hospital and or clinic in another area that may need to provide you with some support. Now, according to the IAF, their recommendation is that you should have these in terms of your medical preparation with respect to the team and supplies. Medical physician with training in emergency medicine. And that's why that is so important. There's that link between sports medicine and emergency medicine. And in fact, this is a requirement, not just that you have a physician, but the physician should be trained in emergency medicine. And we are finding more and more persons getting involved in that, right? And then, of course, you may have to consider your support staff, your athletic trainers, physiotherapists, and so on. And you may have first aiders because they can help you with minor things and freeing you up to deal with more urgent and serious matters. And we spoke about the ambulance and the driver on standby. And you may have to consider your allied healthcare workers. Do you need massage therapists, chiropractors, acupuncturists? That is something that will be determined by the type of sport and perhaps by the budget as well. It is recommended that you have an emergency action plan, not just that you have people on board, and you know the nearest hospital is University Hospital, for example, but what is the plan to get there? What would happen if indeed you have an emergency and it's in the middle of traffic? How would you proceed? Do you need to get a police escort, et cetera, right? Because sometimes people don't really pay much attention to an ambulance siren. So you need to look at your route of evacuation, your supplies, and the protocols for serious injuries. What would you do? It's not sufficient to say, yes, I have a serious injury, but how do you proceed after that? And then it is recommended that you would have your triage and first aid measures, and that's pretty much what we are looking at. Now, when we look at our standard triage assessment for trauma, for example, We're taught in ATLS about the primary survey and the secondary survey. We know the primary survey includes the A, B, C, D, E approach. It is designed to detect live threats, and you begin treatment. Whatever you identify that requires immediate attention, you treat that. And once you've stabilized that patient, you then go on to your secondary survey, which will help you to detect other things that may require attention once you have stabilized the patient and gotten rid of the live threats. And it requires a complete examination in the way we speak about the head to toe, front and back approach. Now, we're going to talk about how triage might be a little different on field, but I want to make this point that during competition, triage begins by watching the game. And this is very, very important for the physician because it can give you a lot of information about the mechanism of injury that if you were perhaps to rely on second-hand or third-hand information, the mechanism, a potentially concerning mechanism of injury might be downplayed. So I usually ask that I watch the game. I want to see what's going on, okay? So for the on-field triage, I developed what I think or kind of called a modified primary survey. So we have the A, B, C, D, which we know, disability and so on. But the E, in the E, we learned the E is environment. And, you know, part of that, you look at all the various factors of the environment. But E here, very quickly, is your AED use. Okay, so pretty much you get that quickly because you are not in an emergency room area. And the aim, if you look here, you have some decisions to really make quickly. Quick treatment and return to play right away, remove to the medical station, right? Or does this patient require immediate transport to the hospital? And really that's a sort of crux of your on-field triage, which is a little different from a triage in a hospital setting. You're dealing with one patient, and we're just taking that you're dealing with one patient at a time. So this is the sort of approach, right? Now, there is no secondary survey on field. You will understand a secondary survey is not going to happen while you're on field to check from head to toe, front and back, and so on and so forth. The idea is that your primary survey, that modified approach, is what will take place on field. And then you will, if you need to, will conclude your secondary survey away from the field. So what are sort of the decisions that you make on field at the moment that you are asked to evaluate that athlete? So is there an injury, right? You require clearly a rapid assessment. The nature of the injury. Is it something that you need to worry about, right? How much injury? Is it just a little thing? Is it a multiple trauma? Is it how severe is the injury? Can you treat it on the field? Sometimes you can. And if that is so, then life would be easy. So you make a decision that you can treat it on the field. You may have to consider, does it require imaging or advanced resources, right? Can the athlete continue to play? That's important because, and that is something we must not downplay, because for most of us who deal with athletes, and especially the more elite athletes that you have to deal with, one of the big things you have to, their sole purpose is to continue to play. And you will have a hard task, right? If you have to manage such a patient who insists they must go back, but you may feel that there is something that will endanger them. Right, but you need to make that decision. Can that athlete return to play? Right. Now, there's a guideline document that is given that allows physicians and other healthcare workers to sort of guide as to what are some of the things that to triage and then to help you to make a decision. And it's divided, and we're going to talk about the red criteria, which is really high risk for serious injury. And most of us will recognize these, and I don't think these will give anybody any trouble in recognizing that these are serious. Clearly a skull deformity with a suspected skull fracture, penetrating injuries, suspected pelvic fracture, so on and so forth, amputation proximal to the wrist or ankle clearly doesn't require any major degrees or a sports medicine degree to identify that this patient is high risk and therefore needs to move on quickly, right? Then there's some mental status kind of factors or parameters, so persons are able to follow commands. If you're particularly breathing too low or breathing too fast, any respiratory distress, room air pulse oximetry less than 90%. Notice that these things will require that you have the support to do that. So you should be walking on your feet in your bag with a pulse oximeter, okay? And then there's other things that perhaps you may not necessarily do on field, like take a blood pressure on field, because a lot of sports will not allow you to do that. But you can make determinations quickly about whether or not your patient is in danger. We all know these systems, either the AFPU or the GCS. Well, it's the same, nothing is different. And you will make, and it's the same sort of level of concern. For example, if you have an A, or rather, if you have let us say a P, that's a little bit more concerning than if you have an A. And of course, we all recognize a GCS. Everybody will say a GCS 8 and below would be cause for concern. But I would say any athlete on the field with an altered GCS should be removed at least to the medical area, the medical station, and be further assessed before a decision is taken as to whether that patient should be returned to play in the same day in the same game. All right, so if you put everything together, if you have all of these, or any of these rather, not all, if you have any of these in the right age and so on, these patients should be transported to the highest level trauma center available to you immediately. So there's no, let's watch and wait and see, okay? So I put in here a little bit for mass casualty. We're not talking too much about this, but it's based on the 5 S's or the principles. Scene safety, we all know about scene safety. One of the things that Dr. Thompson's simulation will teach a medical student, the first thing to talk about is scene safety. Scene size up, send information. So you're going to make sure that you're going to send information to lots of different persons. You may need to send information to your incident command post. You need to send information to the hospitals and so on. You set up and then you start. And start is a simple triage and rapid treatment. And that is a sort of quick a mnemonic developed to help you identify rapidly persons who are at higher risk for a bad outcome in a short space of time. And these really are it. And again, for the emergency physician, we would recognize this: spinal injuries, suspected fractures, soft tissue injuries, dental injuries, ocular injuries, and head trauma. And I put concussion here. And I put it in asterisk because it's very, very important that this is a whole different kind of discussion altogether. And we cannot talk much about concussion here in the time allowed, but concussion injuries have their own set of parameters and rules and regulations as to how they are handled. So that's a different ball game altogether. So pretty much we always begin at ABC. There's nothing different here. And you have to make a decision as to whether or not there's immediate hospitalization is required. And then you will initiate intervention. So who gets immediate hospitalization? Clearly anybody cardiac arrest that you have to you will have to start CPR on. That's not somebody who, even if they recover, you're going to say, okay, that's fine, let's go back to play because you look okay. That person requires hospitalization. Anybody with altered mental status and spinal injury. So in a sort of it's a quick way in terms when you have your mass casualty. Okay, you're not doing a lot of intense stuff. You're making a rapid, if it's triage tool. And then you initiate intervention or treatment as necessary. So just going to look briefly at some injury types and give what the recommendations for treating persons on site. So we know about protecting spinal injury in patients who we suspect that, especially if there's a cervical spine injury, we want a collar that is not a soft collar. You need a backboard before moving that athlete, and you prevent overheating or cooling. Now, although I put that here, we're talking about triage, because one of the things you have to determine is whether or not, yes, a patient with spinal injury needs to go on to the hospital, but do you need to do anything in between? And of course, steroids it's on again, off again. And you may need to have a discussion with your receiving hospital to determine whether or not they think that you must give this patient steroids prior to transporting them. For suspected fractures, we know we should immediately mobilize, okay? Ice packs to the area, well, that's another little controversial area, but most persons will agree that there is some benefit to offering ice in the first 6 hours of the injury. And then you may need to transport to the hospital either for imaging and or further treatment. Now, not every fracture needs to be treated as if it's going to be life altering. You may delay sending such a patient to the hospital depending on the type of fracture, and so it has to be simple, perhaps non-displaced and so on, and in an area that you're not clearly, if you suspect a femoral fracture, you're not going to say, well, you look fine, let us wait. So that's going to be a decision that's going to be taken on a case-by-case basis. Any open fracture, of course, is cause for concern. You apply a sterile cover and immediately transfer the patient. You may have to give them consider. It's not a necessarily a requirement depending on your resources, but you may have to consider things like tetanus, giving them tetanus and or antibiotics if you have them, but you should not necessarily delay the transfer for that, okay? So this is what the IAAF says. Do not attempt to straighten a misshapen bone or joint to change its position. Now, most trained emergency physicians might balk a little bit at that. And I think I would say most of us, we're taught, especially if you have an ankle dislocation, you're not going to just say, let me just, splint it and send it to the hospital that is half an hour away. We're going to attempt to do that. But of course, it is, I believe that this is left to somebody trained to do so, okay? So if you look at some ligament injuries, usually grade 1 is mild, no instability, minimal pain, minimal bleeding, minimal swelling, pretty much something like that. Then analgesics, ice, return to play. The person can return to play if this swelling has not increased, their pain has decreased, and there is pretty much no evidence of instability. So you can quickly take this patient off, do a little bit of treatment in your medical station, reassess, and the patient can return to play, of course, depending on the type of sport, yeah? Now, if you have a grade 2, which might look like this, you see there's a nice contusion here, significant swelling, there's going to be limitation of mobility, the person is unable to walk on the limb, then you have all these various mnemonics to include ice or no ice, rest, but you must remove this person from play. So this is not the type of patient you're going to treat and send back on to play. And clearly this one is severe, and I don't think that, it's going to be what I might call a no-brainer. There's instability, There's no ability to bear weight on the limb. You see evidence here of bleeding, significant swelling, and so on. Clearly, this patient will require some intervention by UES, elevate, rest, and compress, maybe remove from play and transport this patient to an institution that can deal with that, all right? Now, there's some things to be careful of. Inspection alone won't work with all ligament injuries because it may not necessarily be visible. A grossly swollen limb may affect assessment for stability. So you may not be able to determine if the limb if the joint is unstable. In a setting like that, what we say are on the side of caution and have this patient transported where they can be further assessed beyond your ability to do so on site. All right. And again, a painful limb may also affect assessment for stability. Right. So in any patient who has a grade 3 ligament injury, there's bony tenderness, and or you have a situation where the person would satisfy a clinical decision rule, for example, the Ottawa ankle rule. If it becomes positive, that is somebody you have to consider a fracture, and you may very well need, one, you're going to need to remove that patient from play and send that patient further on. Anyone like this, we know is going to be a problem. This patient clearly needs to be removed, and this patient will need to go to hospital for further evaluation. Okay, and we've seen pictures, we've seen some of the very dramatic dislocations that can occur. Always consider vascular injury. Give them some analgesia. You may need to sedate them because you may need to reduce. And again, this depends on your level of expertise. Consider a fracture in cases where, especially in like a football injury and so on, it may very well be associated with a fracture. Remove from play. Definitely you need to remove this person from play, and you will have to, I would say, reduce it promptly, okay? Reduce promptly because we're worried about that vascular injury. We're going to splint and we are going to send for the hospital. Pretty much the same thing with an elbow dislocation. We do have vascular things we need to be concerned about, especially when you have this dislocation as you see here. So you want to ensure that you reduce this as quickly as possible. Again, it's going to be dependent too on your ability to do it, your expertise. And I don't presume that every single time you're going to have an emergency physician, but in such a case, this is a patient that needs to move fast, okay? Knee dislocations, again, they're dramatic, they're awful looking. You want to make sure this patient try to reduce it as quickly as possible. If you can't, don't delay transfer of this patient to your hospital, okay? So for the management principles in terms of limb injuries, we know, say, forget how awful the joint looks. The danger lies in what you cannot see. And most of the things that you can't see that's going to be worrisome would be those vessels, those blood vessels. And it's not about the bones, all right? It's not about the bones at all. So you do have a little bit of time, according to the experts, that you have 6 hours, that, you know, there should be some sort of that can be compromised circulation and you still have a good outcome. The point is, recognize that this patient needs to move. Either you're going to reduce it promptly and move, or they need to move very quickly. You do have some time, but start the process right away, right? Because admission is strongly advised, this patient should be in a hospital, should not be managed by you, waiting for the end of the match. All right, so in terms of your transfer bottom line, the after your ABCs, and these are the things that you want to consider that they are bad things, right? So vascular injuries, long bone fractures, open fractures, joint injuries, and major joint dislocations that cannot be reduced. And of course, I presume your ABCs, you know, it's airway, breathing, and all the circulation things that we worry about. So now some things that are not, we don't necessarily see a lot of, and therefore sometimes we get a little bit concerned as to when it happens, what do we do? So sports and dental injuries, I think, go hand in hand. Clearly, contact sports are going to be far greater than non-contact sports. And the ones that are, you have to watch basketball, football, hockey, hockey, oh my gosh, hockey, martial arts, and boxing carry the highest risk. Okay, anytime I have to cover a hockey match, I literally sit on edge because it is that bad. Mouth guards are useful, but they are not 100% protective. All right. And some of the things that you would worry about are your tooth fractures, avulsions, and so on. So let us look at dental injuries. So after airway, breathing, and circulation, one of the things that the dentist will say is called, the C is called for a dentist, okay? So crown fractures are ones that look like these, like that. Now, if you have it, we don't. You could cap with some calcium hydroxide resin. If you don't, just cover it and refer to a dentist, right? And all dentists will tell you, refer them to a dentist as soon as possible. Now, you have the intrusions and the extrusions. You just pretty much, these happen. I've never seen one of these. We've seen the avulsion type, so I've not seen this. And, you know, we hear a lot of things. You want to handle the crown only if this happens, right? Only if it's permanent teeth would you attempt to reimplant it quickly. If it is done early, 5 to 10 minutes, you wash with sterile water, no aggressive washing, you rinse the tooth with normal saline, reimplant, and you split, okay? If you can't reimplant, then that's fine. Don't force the issue. Just store the tooth. You have some or commercially prepared solutions. You'd have to have skim milk, but any milk would do, and that is cold or saliva. Store it in the patient's cheek. Of course, you have to make sure the patient has a GCS of 15 to be able to do that, because you don't want another issue, right? Or put it in some saline or water and include any pieces of the tooth, transport it, and you give it to the dentist, right? So for an avulsion, a splinting option, just ask them to buy down on a handkerchief or gauze, right? You can have a mouth guard. If they have a mouth guard, use a mouth guard as a splint. I've seen aluminum foil, just make one and put it there. And then you have the stoma adhesives, which are specially prepared commercial things that you put on to hold the tooth in place. So I'm going to finish up here with, well, it says, what say you? And this is meant to be interactive, but you can perhaps guess, write it down in the chat and see if we all agree. So you have a TMJ dislocation. What do we do? Question is this cause for concern? Do we reduce and send the patient back into play, or do we just go straight to the hospital? So these are some things that you want to consider. So using our little triage system here, quick treatment and return to play, remove to medical station, immediate transport to hospital. Now, if it is uncomplicated and you don't suspect a fracture, you probably could do this, meaning a quick reduction, but sometimes they're not so quick. So it might be best to just move them to the medical station, where you may have to give them some a muscle relaxant and do the reduction yourself. And really and truly, unless there are other issues, if it's an uncomplicated TMJ dislocation, you can actually send them back to play. Okay. Now, this one, I asked Dr. Mansingh for, because I remember he had done this a long time ago, and this was, you see, I'm forgetting the name, but anyway, this was a cricketer, an international cricketer who was injured during play, and what he had was a fracture of his mandible. So what would you do? All right, A, B, C, D. Well, we don't need any AED use here. He does have an injury. It's a fractured mandible. If you see, he's spitting out blood here. So he needs some care, right? So would you do a quick treatment and return to play, move him to the medical station, immediate transport to hospital? Okay, I'll tell you what Dr. Mansing and his team did. All right, so this was a mandibular fracture. So he was triaged nicely, but not because a decision was taken. I think this was the last over of the match, and they were about to win. So to remove him might have been a problem, right? So what happened? This is what happened. He was actually nicely splinted, bandaged up, given some pain relief, and he returned to play. And I do believe they won the match because of this. So sometimes the decision is taken not just on the injury itself, but on other aspects of the game. That's what sports medicine, that's why sports medicine is a little bit exciting, right? So preparation is key. Anticipate the type of injuries. Remember that triage begins by watching the game. Mechanism of injury is very important. Decide fast what needs emergent care, and then don't delay that care. Regardless, ABC always comes first, and that hasn't changed in all the years that we've been doing this. Consider returning the injured athlete to play. And you consider that by not just the type of injury, but by the effect, by the other factors of the game, all right? Can the athlete play on even though they have an injury? That requires care and requires prompt care. But how prompt? Yes? Do you have a few minutes to spare like the cricketer? Thank you very much for your time and attention.
Wow, enjoyable, Dr. Hudson. Really, really enjoyed that talks on sports injuries, field injuries, athlete triage in sports medicine. I mean, I'm not sure if well, I guess the guy was winning, so Dr. Mansing had no other choice. And as you said, sometimes these decisions are not only based on the injury, but you have to consider it was the last over and they needed to win. All right. So thank you to everyone. My technical team, they've advised me that there are questions in the chat. So I'm going to read them so that our presenters can answer quickly. Dr. French, this one's for you. Based on your finding, do you think this device, meaning your ultrasound machine, your butterfly, is suitable for routine use or only in emergency situations?
So first of all, I did type a response in the chat, but I realized we're on the presenter Zoom, so perhaps you could copy and paste it into YouTube. But basically, the butterfly device is really, at this point in time, best applied in a point of care setting. We must be reminded that what we're talking about today is the use of ultrasound for point of care, as opposed to what a radiologist does, where they scan the entire abdomen, looking at every single organ, every crevice and corner. When we incorporate ultrasound into clinical care, we're typically looking at something. Is this cholecystitis? Do we think this is appendicitis? Is there free fluid? Do we think there is trauma with an injury that requires, advancement of care? It's a different thing. Now, why is it that we think at this point in time, the point of care devices will remain in that domain? Well, for two reasons. The image quality is they're still not quite there yet compared to the really high-level cart-based machines. Also, bear in mind the screen size. So typically these handheld devices, the screen size may be as small as a cell phone or may go as high as an iPad. But certainly for persons, when you're learning and to try to see, a lot of minute detail, that might not be the best for that. However, I'm here to tell you that the image quality is improving rapidly. And certainly the new IQ3 compared to the butterfly, the previous generation, is getting very good reviews. They did have an issue as it related to cardiac images. They seem to have fixed that. They've listened and they've reduced the head of the device to make it smaller, to make it easier to image between ribs. And so as technology advances rapidly, we may see a time where these small devices are good enough for radiology type scans. We shall see. And I look forward to giving that talk if and when that happens. Thank you, Dr.
All right. All right. Thank you very much for that answer, Dr. French. Another one for you, Dr. French. It seemed to be popular. In Ghana, where I was trained, that is Natapia 2035. In Ghana, where he was trained to become an emergency medicine nurse. Awesome. Midwives are trained in POCUS for midwifery practice. Some emergency medicine nurses also use it in the US. Any comment on ultrasound use by nurses or midwives in the Caribbean?
So first of all, I'm going to ask you to again copy over that response and place it in the YouTube chat because I would want everyone to have access to it. So thank you so much for sharing your experience. And this is exactly what I was alluding to as I said that, paramedical staff as well as nurses in other locations are already taking these steps. Interestingly, the Jamaica Handheld Ultrasound Program did provide devices to the for antenatal screening, and the intention was that doctors in clinics, you know that in Jamaica we have clinics out in the community where persons go for antenatal care, and the intention was that doctors and midwives be trained. Now, truthfully, I am not on the obstetrics side of that project, so I cannot say whether the midwives were actually trained, but I think that it's going to get rapidly. I believe that these things are not only will they train midwives, but it will be very likely that these things are embedded in post-basic courses for emergency room nurses, for midwives, because the advantages are just obvious. And once they have the training, we know that persons who are properly trained can apply the training. So that's where I think it will go. But thank you so much to that viewer for sharing that experience. Thank you.
Okay, so last one for you, Dr. French, again.
Wow.
Based on your findings, do you think the butterfly ultrasound is suitable for routine use or in emergency situations?
I
Which
think that
one do you think?
routine use, well, okay, so butterflies, I can tell you, personal experience. My mother worked overseas for many years in the diplomatic corps. When she had a DVT, she did not go to the hospital. The part of the world she was living in, it was not considered to make sense to go to the hospital because they had very little. But she was seen at home by a doctor who was proficient in ultrasound, who diagnosed her DVT and treated it at home. She never entered a hospital. So as we say, ultrasound is not just for emergency medicine. It's not just for hospital-based care. And this is something that we're considering as we design the platform for ultrasound training here at UWI. The idea is that, persons should be able to access point-of-care ultrasound training that suits their practice environment. So a GP can diagnose a DVT in their office and dispose of a patient who doesn't have any other symptoms and manage that person as we know their outpatient algorithms for management of those conditions. There's no reason then to charge that patient to the emergency room to come and spend how many hours to be frustrated and miserable when you can actually manage that person. What a surgeon will do with ultrasound is going to look a little bit different from what an emergency physician will do with ultrasound, which will look different from what a critical care specialist will do with ultrasound. So point of care ultrasound is not going to be the domain of any one specialty. We're way past that. We're all gonna, and that's why I said I think the barriers to right now we have an issue where I didn't really say much about it, the referral block, right? So now we're getting, funnily enough, a pushback sometimes when we use ultrasound. Oh, we're not going to accept the referral unless you did a radiology ultrasound. And that's a bit unfortunate, but it will go away with time. And it will go away as more persons across more specialties really realize how advantageous and how simple it is to diagnose some of the things that we're talking to them about. On one occasion, I simply just held the probe on the patient and asked the particular resident to look and asked if there was hydronephrosis. They said no. I said, good, can you accept the referral now? So as persons gain experience, those barriers are going to lower. No one would go back to a time when people used to put their ear on the chest to listen to the heart sounds. Once we developed a stethoscope, we wouldn't do that. And there's going to be a time when we look back at this period and say, people didn't use ultrasound? What? So this is how life goes. And, so that's really my answer.
All right. Okay. Thank you for those interesting answers, Dr. French. And no, we're definitely not going back. I think we're going forward with the probe around the neck. All right, so Dr. Thompson-Newell, there have been growing concerns about the effects of biased clinical mannequin usage in training and real practice. Most CPR mannequins are males. Weirdly though, we had Annie, making it difficult to achieve high quality CPR in heavy adult females. 2, skin bruises and discolorations can be identified easily in white skin mannequins than in real Black humans. How can we bridge the gap? Oh, a loaded question.
Well, thank you so much for that question. In terms of the mannequin types, I mean, yeah, a lot of them tend to have, I guess, a physique of small busted patients, right? So larger busted, like women in particular, or men with large busts may not be depicted in the simulation, or we may not be able to effectively depict these in simulation. However, I think the focus is primarily on understand the technique, or ensuring that we capitalize on the skill and the technique that is needed for the particular clinical setting. Even the regular mannequin, they may not fully give you the feel of how a human chest feels, right? The ones that we may be able to afford, but what we tend to focus on is the skill set and the technique and the guidelines that are needed in managing the specific clinical scenario, more so than the physique of the patient. Certainly, there are mannequins that are available that has, a better feel of the texture of the skin, for example, or the physique of the patient. We had a mannequin, or we had procured a mannequin that looks like a patient with Down syndrome at Sick Kids, for example. But these mannequins tend to be, costs tend to be a restrictive factor for these types of mannequin, and so may not be practical or feasible depending on the setting and the funding that is available, as well as the support that may be available to you in your simulation program. In terms of the depiction on, of injuries on dark skin patients, certainly it is a challenge, and what is important is that within your setting, you, based on the types of patients that you see, it's important that if you're procuring mannequin, it's important to try and procure mannequin with similar skin texture as the patient population that you serve. One of the things that we utilize is moulage or makeup to try and depict these injuries or swellings on the darker skin that probably will not replicate as real as we'd want it to be, but it can come pretty close once you have once you have used the moulage effectively.
Or you have trained people like
Sorry?
Or you have trained people like Sister Harris.
Right, exactly. We have Sister Harris who is excellent with applying moulage, and we have utilized that in our exams in particular.
Right. All right. Any other questions? No? All right. So we have two giveaways left. So for a lucky member of the audience, who is the godfather of simulation medicine? That's one question. And my other question is, somebody's answering, and PricewaterhouseCoopers would not have that. And who was the first head of the emergency medicine division at the university hospital? So that's the two
Can I
questions.
answer? Can I answer?
Me first.
No. So the godfather of simulation medicine, and who was the first head of the emergency medicine division at the University Hospital of the West Indies. So we're waiting for those two answers to join Sister Coombs, Matthew Blackwood, Sister King, Sue Ann Ramsaroop, who is legendarily 2281, and then our other two lucky winners. All right, so for question number 5, the answer, Monique. It's Monique, right? No, you have to give me the full name. So it's Monique. Dr. Wait, awesome. So Dr. Wait, I wonder where in the world are you? Dr. Wait is the winner of our 5th gift, courtesy of Massey Distribution. And our last question, who headed the first emergency medicine division at the University Hospital of the West Indies? And that's Melissa D214X. All right, so Melissa, you have to tell us your name. D214X, you're the winner. All right, I know for me, I was intrigued from start to finish, but as they say, all good things must come to an end. Melissa? Oh, Melissa Royal. Okay. So you need to tell us how we can contact you as well. You can just give us an email for us to email you how to collect your prize. All right. Okay. All right. So if there are no more questions, my technical team has said there are no other questions in the chat. It's only left for me now to give the vote of thanks. A mammoth task being asked of me, but I will do my best for this webinar on Emergency Medicine Day 2026. Okay, so first I would like to say thank you to Sister Harris. Your prayer made us calm and relaxed, and everything started to go right after that. Even, the internet was stable. Thank you to Dr. Hudson for her opening remarks that gave us an overview of, Emergency Medicine Day, as well as it challenged us to ensure that we take charge of emergency medicine as specialists, right? The emergency medicine theme was safety for all emergency medicine workers. And so in addition to ensuring that we continue the specialty in terms of the future, we also need to take care of ourselves and our colleagues. Thank you to our keynote speaker, Associate Professor Dr. Burke. We really enjoyed your presentation on the history of this specialty. And Dr. Reginald King, who actually gave us a nice Caribbean tour from start to finish. Sister Nedrick, who spoke about emergency nursing in Jamaica and the Caribbean and its contribution globally. Professor Jean Williams Johnson, Dr. Husang French, Thompson Newell, and Hudson, who gave presentation on the different subspecialties in emergency medicine. I thank you very much. We want to also thank our sponsors, Massey Distributors, for our lovely prizes, and thank Mr. Spencer for detailing us on the BNP machine. I'm very happy that we have access to point of care BNP testing so that we can distinguish dyspnea in our emergency department based on that breathing not properly study. I just want to also thank Dr. Premanand Singh. Through his contribution from Ribbies and CDEC, we were able to provide refreshments for the persons who were working behind the scenes. Would like to also thank the Emergency Medicine Committee members, all the 9 consultants, the senior and charge nurses, the family nurse practitioners, Nurse Practitioner Blake, who, she's always behind me, egging me on and participating in everything, and the ERTs. Thank you to the PR team who made sure that persons were aware of, the function and how to join. Miss Shante Christie and Miss Carrie Ann Robinson. Thank you also for the setup here. Very lovely. Some persons won't be able to see it, but hopefully next year we'll be in person. Thank you to the ED Administration Department, Miss Loy Ann Samuels, Mr. Orville Johnson. Special mention for Miss Loy Ann Samuels because she was the person who designed our flyer. She designed our opening ceremony run sheet, and she was the technical force really behind most of, a lot of all of the things that we had to send out to persons to get them engaged to present. Thank you to the technical committee headed by Dr. Errol Williamson and his little charges, Dr. Jerval Victorine, who advised me, as to what are the requirements, and all I said was, okay. All right. Last but no means least, I want to say thank you to everyone who contributed, who I may not have listed, right? Please don't kill me. And most importantly, our audience, thank you for listening keenly, for participating, right? For ensuring that this webinar was a success, all right? Hopefully I haven't forgotten anyone. Just want to say thank you for being with us for Emergency Medicine Day 2026. And I look forward to you being here in 2027, where we will celebrate another Emergency Medicine Day. Please be reminded, those of you who have won your prizes at Sister Coombs, Dr. Matthew Blackwood, Sister King, Sue Ann Ramsaroop, Dr. Waite, and Melissa Royal, you will get an email detailing how you would collect your prizes. All right. Just want to say a last thank you to all the persons who were instrumental in making this possible. All right. The hospital or head of department, if I have not mentioned you and you were instrumental, I thank you. Thank you and goodbye.
So, Miss, do you wish our picture or not, please?
Picture, yes, picture. I love your lipstick. It's really looking teafish.